Good morning. It's good to see everybody smiling and bright-eyed this morning at 7 a.m. Glad you could make it. Welcome to Labor and Health. We're going to get started here this morning. First, rule of thumb. Representative Larson doesn't know the rule of thumb yet, so we'll tell him. Everybody else has heard this 20 times already. That is, if you have a cell phone, please turn it on to ring, because if it goes off, we like donuts. The first one to go off buys donuts for the committee for Wednesday's meeting. That being said, we should tell you we like chocolate and, yeah, okay. See, some people already know. With that in mind, committee, we got 4 bills in front of us this morning. We're going to try very hard to get through all 4 of these bills. Just for your notice, at 8 o'clock, I have to present across the hall, so Senator Dockstader will take the steering wheel for at least part of the time there at 8 a.m. So we're going to start this morning hearing from Representative Larson on hospital supplemental payments statutory fix. Roll call first. Yeah, see, that's why you're here. We're all here. There's only 5 of us and we can see us. We're here. We won't make that formality. With that in mind, Representative Larson, tell us about a bill that should be familiar to some.
Thank you, Mr. Chairman, members of the committee. This is an upper payment limit bill that you guys had worked during the interim. Just as a reminder, I believe it was in Riverton later in the interim when I was testifying and we were working through some of the things that we wanted to have included in this bill. The Labor and Health Committee was, I believe, on their last meeting or close to it. We didn't have all of the details. It was kind of a conversation between Chairman Baldwin and I on getting the information come in and put it in a bill. And so that's why you see it. Some of this stuff were things that you were considering in the interim bill, but because we didn't have everything that we needed, I'm running it as a personal bill and for that. Mr. Chairman, I would just also remind the committee just at a 30,000 foot limit, the upper payment limit program. The first one we done was for this private hospital program, and we done it in 2016. And as a reminder, in reimbursements to hospitals for Medicaid, they use a rate that's similar to what Medicare provides for a service. So Medicare is a completely federally run insurance program, and when they provide reimbursement for a service, say at $100, they're saying that's what we'll pay for that service. CMS also, in collaboration with the states, run the Medicaid program, and they say for a similar service, state that we partner with will pay, but we won't pay over what we pay in Medicare. And so if that number is $100 and we say for this Medicaid service, the maximum we can get reimbursed is $100, getting that $100 depends on how much the state wants to participate. So Wyoming participates at 50-50, dollar for dollar. Our revenue situation may not allow us to put in enough money on our 50% that we can capture that whole $100, which is the upper payment limit. It may only be $75, leaving $25 on the table, which is important to our providers. And so in 2016, we passed the first one of these where the private hospitals assess themselves a fee that then can be used to enhance the state's portion of this Medicaid to then capture a greater federal side, and then we can go get that $25 that we left laying on the table. And now, so our first one is in 2016, then we got one that applies to nursing homes, I think a couple of years later, and then I think a couple of years ago, we done one for our EMS services. Now, when we done this first one in 2016, we were a little unsure. It was new, and we wasn't quite sure how CMS would, if they would approve our amended state Medicaid plan. They have, but at that time, we made a requirement to come back every year to authorize that that plan. So every year in our budget bill under the Department of Health, we have a footnote that says that they have to reauthorize the private hospital upper payment limit program. We don't require that on the nursing home, nor do we require it on the EMS, because that's in statute. CMS doesn't require us to come back annually. And so on the first thing we do in this bill is at the bottom of page 4 and top of page 5, where there's new language, is we put in there that the department is deemed to satisfy this requirement, boom, so that we don't have to have that footnote every year in the budget bill. So, and so that gets rid of that antiquated requirement. That's the first thing we do. The second thing is in section 2 on page 5, where we authorize the Director of the Department of Health to request permission to amend the state Medicaid hospital upper payment limit program to include services provided in a psychiatric treatment facility. So and the reason for this is we have one private hospital that currently has a PRTF, and we have another individual PRTF in the state. What we're trying to do is include, it's very important, is to include PRTFs in the services that are able to participate in this upper payment limit program. We have found that PRTFs provide services to adolescents with high behavioral needs, and it is not uncommon around our state, because that is one of the gaps in our state, is providing services to adolescents, is that you may find an adolescent in a private hospital around the state and not getting the services that they need. So the hospitals have come to us, and one of the reasons is the PRTFs, the two that we have in the state, have had trouble getting reimbursed at the level that will allow them to take these high behavioral cases. Okay. So this allows, section 2 allows the Department of Health to make that request to amend our Medicaid plan to allow PRTFs PRTF services to participate in this upper payment limit program. If you'll turn to page 6, section 3, this appropriates funds generated from the hospital's assessment. Remember, we talked about that. The hospital makes an assessment and a like amount of federal funds to the Department of Health to accommodate the participation of hospitals providing these PRTF services. So that 3.8 million, of course, is an estimate. We get that from the federal funds and from the assessment made by the hospitals. The fourth thing we do is found on page 7 in section 4, where we allow an additional position to the Department of Health to administer the upper payment limit programs. You'll see in there that we identify the Wyoming Nursing Care Facility Assessment Act, the Wyoming Private Hospital Assessment Act, which is the one we're focusing on today, and the Private Ground Ambulance Assessment Act. All of these have increased the burden on the Department of Health. When we started in 2016, they handled it internally, and now they're the point that it warrants an additional person. So we're allowing this to take place. Part of that funding is created here with $48,000 in federal funds, 50-50 match. The other half comes from the assessment there's a portion of the assessment that we'll get to later in a little bit that allows the Department of Health to use for administration. That's where we get the other $48,000, so it's about $96,000 a year to help do the administration of these three acts. The fifth thing we do is on page 3 and 4, and each hospital assessment is based on a uniform percentage of the hospital's net patient revenue for each fiscal year as determined by the Department of Health, needed to capture but not exceed the upper payment limit dollars that we've left on the table. The Department of Health is not allowed to increase this assessment by a percentage each fiscal year, which is currently 0.5%. With the addition of the PRTF, you'll see there on the top of page, on the bottom of page 3, that we allow that to increase not up to 1%. So there's a cap of 1% that the increase can take place on each fiscal year. Then the second thing we do, there is on the top of page 3, where the administrative expenses incurred by the Department of Health that come out of the aggregate assessment from all that's collected has been 1%, and it's raised to 3% here for the extra burden of the PRTF. On page 4, Mr. Chairman, we under 429106A, we delete or remove some antiquated language going back to the year this UPL program was started, and add the clarifying language of private hospitals. And then on C, there on line 12 where it starts, we add clarifying language that we remove that language of inpatient outpatient services, because with the new language with the addition of PRTF, that becomes confusing. So, Mr. Chairman, I'm happy to go answer any questions and go into far more detail if you would like, kind of hit the high points there, knowing that this committee has seen this before.
Thank you, Representative. Just off the top of your head, and you may not know, do you know the outcome of any of those other 3 programs? Do you know how well they've performed?
Mr. Chairman, the nursing home upper payment limit is working well. And recall, that was nursing homes attached to a hospital. And I believe that that's been very successful. The private emergency medical carrier is still in rulemaking. I think that they anticipate that that'll be completed and available this year.
Very good. Further questions? Senator Dockstader.
Thank you, Mr. Chairman. Representative Larson, you may have gone over this, page 5, line 5, modify the payment. We just simply did not have the flexibility to do that in the past, correct?
So, excuse me, Mr. Chairman, Senator Dockstader, could you give me that reference again?
Page 5, line 5, words modify payment.
Yes, and so what this is doing is this is the new language that deletes the need for the footnote every year. And while seeking federal approval under this subsection, the department may modify payment or qualifications as necessary to obtain CMS approval if changes do not exceed the authority. So it's leaving in there the authority for the Department of Health to work within the program.
Understood. Thank you.
Further questions, committee? Senator Barlow.
Thank you, Mr. Chairman. Good morning, Representative Larson. So hospital services, the definition on page 2, there's basically two groups: a private hospital, and then there are practitioners employed other So my question is, that second category, well, I'll have 2 questions. The second category, that could be distributed over public hospitals, it seems to me, because that's a practitioner group, or can it be? And the first and the other part of the question is that practitioners employed by et cetera, is actually distributed in section 2 and 3 of this bill. But what is not in that other section is the private hospital part. And I can point those out more specifically, and maybe the Department of Health will have an answer. But I just want to understand that I understand what hospital services is, and includes these 2 categories or types. But does the second category actually speak to public hospitals potentially? And then should we be consistent in the rest of the bills, particularly sections 2 and 3, that private hospitals also included in the descriptor? Thank you, Mr. Chairman.
Representative.
Thank you, Mr. Chairman. And Senator Barlow, also, if you'll look on page, it starts on the bottom of page 5. and it talks about an affiliation. It talks about affiliation with the hospital be specified in the state Medicaid plan and shall include a public or private hospitals as authorized by federal law. And so again, we kind of reach beyond the private and include the public. And there's method to that madness in that currently the UPL is for private hospitals. However, if the two PRTFs in Wyoming, one being WBI in Casper is a private hospital that provides PRTF services. The other, of course, St. Joseph's in Torrington. The director, or the department, I should say, of health, as they've looked at this, there's some feeling that they may be able to, down the road a little bit, may be able to include St. Joseph's affiliation also with public hospitals. And so this is kind of preparatory language to lay that we may amend this in the upcoming years.
Further questions, committee? Senator Hutchins.
Yes, thank you, Mr. Chairman. Representative Larson, back on page 5, the sections 4 through 8. I believe you said that the Department of Health did not have this authority before, and now we're giving it to them. If I heard you right? Thank you.
Mr. Chairman, and I want to make sure, Senator Hutchins, that I'm understanding your question. We received authority in 2016 to do this PRTF. The CMS has not, from that point on, has not required us to come back for reauthorization of our state plan on an annual basis. However, when we applied, we made the assumption that that may be a requirement that we would have to comply with. So we have been coming back each year with a footnote. Now we're saying in this new language that the department has deemed to satisfy this requirement by seeking that approval. And so we do have the approval from the federal agency that approves this, and with the flexibility to adjust those payments as warranted in the program.
Thank you.
Okay, further questions? Seeing none. Thank you, Representative. Stand by.
Thank you.
Let's go ahead and bring the department up next.
Morning, Stephen.
Morning, gentlemen.
Morning, Jesse.
Morning, Mr. Chairman, members of the committee. Stephen Johansson with the Department of Health. I'm really just here to stand for any questions. As Representative Larson mentioned, the Labor Health Committee worked this for most of the meetings during the interim, I think going back into June. The process to do these programs is quite complicated. The concept is quite simple. So as Representative Larson mentioned, this is a supplemental payment program we have for private hospitals, and we've had for a number of years. The idea here is really to add psychiatric residential treatment facilities and their services as beneficiaries of the current program, where we increase cost coverage for providers by nature of drawing down these funds, these additional federal funds. What I wanted to mention to the committee, Mr. Chairman, is that this, as was discussed with the Labor Health Committee during the interim, this will be exploratory this year. Having this approval to do it, we will seek the state plan amendment to explore with CMS the ability to add psychiatric residential treatment facility services to this program. There's a variety of different ways that can happen. We've worked with the Hospital Association and the providers to determine what those routes would be, and we think we have a good path forward. But again, I wanted to make it clear to the committee that this authority doesn't start the program immediately. We would need to seek that approval and then put the necessary steps in place for it to start. So likely, as we discussed during the last interim period, we'll have the ability to report back to both this committee, appropriations, the legislature in general on any issues or any needs. But as Representative Larson mentioned, we have these programs running in a variety of different areas, nursing homes, private and public hospitals, physicians affiliated with hospitals, and now, as was mentioned, that will be starting soon, ambulance services as well. These programs in my mind are quite successful in being able to increase cost coverage for providers without appropriating general funds. And we, as a state, don't do these unless the provider group is willing. These are not forced on the providers. It's a way, again, with minimal state costs to increase that cost coverage, increase reimbursement, and thereby increase access to the folks who receive those services in communities across Wyoming. In this case, the PRTF services are for a very specific population of adolescents with extremely high behavioral health needs, and we only have 2 providers in the state. So I think one question that I'll preemptively answer is, why would the hospitals, private hospitals, want this to happen? Why would they want to increase assessments on themselves to benefit psychiatric residential treatment facilities? And the answer to that is because we often see, unfortunately, adolescents with high behavioral health needs in emergency rooms, in those hospitals that we're talking about. So there's an upstream and a downstream impact and benefit for any tools that we have to, again, increase that cost coverage, which thereby increases the business's ability to cover their costs, to staff their facilities, and hopefully take additional safety net patients that we have. So the department, of course, is supportive of this bill. As we indicated and worked with you all during the interim, we think there's a path forward here that we'll explore with the feds. And with that, Mr. Chairman, I'll note I have a UPL expert with me to my left, Mr. Jesse Springer, who works with our Medicaid office. We're happy to stand for any questions you might have.
Question, Senator Dockstader.
Thank you, Mr. Chairman, Director. Adding ambulance services, what does that do? What's involved with that? You just kind of touched on it.
Mr. Chairman, Senator Dockstader, just to clarify, we have separately an upper payment limit or supplemental payment program for ambulances that was authorized, I believe, 2.5 years ago. And we've been in the process of standing that up, which should take place this year. So no additional, nothing's needed within this bill.
Further questions, committee? Go ahead, Senator Bouchard.
Thank you, Mr. Chairman. A lot of this language looks similar to me. I mean, when the former chairman of this committee explained to me that there's ways that they use to get more Medicaid money into the state with matches. So what total Medicaid money comes into the state have you estimated in this?
Director.
Mr. Chairman, Senator Bouchard, if I may clarify, total federal dollars that come into the state or just through the upper payment limit program?
Go ahead.
Mr. Chairman, just through this program, how much will we increase the Medicaid?
Director.
Mr. Chairman, Senator Bouchard, thanks for the clarification. We estimate that this would increase federal funds into this area, private hospitals, and thus psychiatric residential treatment facilities by approximately $3.8 million by nature of collecting that $3.8 million upfront. In terms of what the private hospital upper payment limit program currently collects, I'd have to have either Mr. Springer answer that or we could get back to you. But the addition through this bill of federal funds would be about $3.8 million. And I will mention for the committee, because it's important to note, we are maxed out in these programs. We cannot assess more than 6%, I believe is the federal threshold. So it's not that the department would have the authority to keep assessing providers. If we exceeded a certain threshold, there is a ceiling there. But the whole goal here is, as Representative Larson mentioned, there's a certain level that Medicaid cannot pay more than. It's part of the Social Security Act and Medicaid authorization that we cannot go over what Medicare would pay. That, quite simply, members of the committee, that limit is the upper payment limit. That's what we're referring to. So that's essentially the gap that we're trying to close.
Further questions, committee? Seeing none. Mr. Springer, would you like to add anything to that?
Chairman Baldwin, Senator Bouchard. So currently the hospital and physician programs, I don't have the breakout of the private hospital program because I see these as all, we actually have multiple programs, so they layer. So, but just for total hospital and physician programs, there's $50 million net already existing before you pass this, if you pass this bill. That is additional federal funds that's coming to Wyoming because of the various supplemental programs that have been built over the decades for hospitals. So there's hospitals, private hospitals, the physician program that was added. So those are all being paid to hospitals. So this would be an additional program. So that, and to the number that was mentioned was 3.850. So 3.8 million, 3.8550 additional funds, which is in the appropriation.
Additional questions? Seeing none. Thank you, gentlemen. Let's bring Mr. Boley up, and we'll bring two people that are online, Ellie Cochran and Joseph Garachi. Go ahead and bring them in at the same time.
Morning, Mr. Chairman. Eric Boley with the Wyoming Hospital Association, and I've invited both Rhonda and Mike to join me up here. This is who this bill is going to affect. I'll let them introduce themselves.
Good morning, Chairman Baldwin and Senators. My name is Rhonda Meyer. I'm the Executive Director at St. Joseph Children's Home in Torrington, Wyoming.
Good morning, Chairman Baldwin, members of the committee. I'm Mike Phillips. I'm the CEO at Wyoming Behavioral Institute in Casper, Wyoming.
Mr. Chairman, if you want, we could have our legal team introduce themselves, or we can just go ahead, and then if we need them, they can jump on, whatever you'd like us to do.
Ellie and Joseph, go ahead and introduce yourself. Whoever wants to be. How about Ellie goes first?
Thank you, Mr. Chairman and committee. My name is Ellie Cochran. I'm at Hush Blackwell, a law firm. We're out of Austin, Texas.
And we assume the weather's better in Austin, Texas than it is here.
And my name is Joe Geraci, and I work with Ellie.
Very much. Welcome. Go ahead, Mr. Boley.
Thank you, Mr. Chairman. We won't spend a lot of time. I won't spend a lot of time. I think it's important that this committee hears from our two PRTFs in the state. But what I would say is that these UPL programs have been very, very successful in our state. They've been needed as we look at the budget shortfalls in all these different areas. Before I even came to the association, we had a couple of UPL programs that were enacted. One was for the governmental hospitals, and another was for the nursing homes. And as I look at this panel, every one of your communities benefit from those programs. And then we did pass the private hospital UPL. We worked on another UPL program that would help nursing homes that are not governmental. And then we also did the EMS UPL and the physician supplemental payment UPL a couple of years ago. I have been working during the session when I have time on getting that EMS UPL program stood up, and I think we're getting closer and closer every day. As I met with our legal team more than a year ago, almost a year and a half ago, the thought of creating a UPL to help our PRTFs came to mind, and I'm honored and blessed to represent WBI. And I didn't know a whole lot about St. Joseph's until this whole thing came up, and I actually went and visited their facility in Torrington, and I was moved by what they do there. It's an incredible mission that they have. And these are some folks that really, really need our help, these adolescents that are treated in these two facilities. But we became aware of a significant shortfall in budget. And so instead of coming to the state and asking for general funds, which is what could fix this, because for every dollar you put in, we get $1 of federal funds back, we decided to come with our own solution. And that came by partnering with the private hospitals that treat a lot of these patients and end up with them staying in their emergency rooms for extended period of times. And they don't receive the treatment that they need while they're in those emergency rooms. They really need to be in these two facilities, the PRTFs in our state. So we worked with our legal team. We came up with the idea of proposing an upper payment limit program that would benefit PRTFs. And this will be funded by an assessment to the private hospitals. And then that money will be distributed to both WBI and St. Joseph's to help them in their mission to treat these patients. I think a couple other things I'll just touch on, and then I'll let them tell you their story. We are significantly underfunded in this area. We have difficulty having these patients go anywhere in the state, let alone outside the state. Our rates are so low that we can't refer outside the state because the other facilities outside the state will take other states' patients before they take ours. We have capacity in some of these facilities, but we don't have the ability to care for them because we're short on staff and we're short on resources. And that's why I think that this bill and this program would really benefit St. Joseph's and Wyoming Behavioral Institute. I'll stay here for any other questions, but I think, like I said, I think it's important that you hear from them. So I'll turn the time over to them unless you have any questions for me at this time.
Any questions for Mr. Bully? Go ahead, Senator Hutchins.
Just a quick one. You kind of know where I'm going. We have 2 hospitals we're trying to fund here in Wyoming, correct?
Mr. Chairman, Senator Hutchins, there are 2 PRTFs in the state, yes.
So let's just kind of, if you could, because I'm not very good with math, but maybe you can just kind of help me here, play with me. We have 50 other states that probably have more hospitals than we have, correct?
Mr. Chairman, Senator Hutchins, yes.
So they're probably doing the same thing we're trying to do. That's another step. So I'm just trying to wrap my little head around the fact that we're gonna all be gleaning from one pool or bucket or pot of money from the federal government to fund 50 states with God knows how many hospitals. Do you have an idea how much money the federal government is gonna have to send out to satisfy every state? If that makes sense to you.
If you want to answer that or can't answer that.
If you can't,
Go ahead.
you can't.
Well, Chairman Baldwin, Senator Hutchins, I would say that not every other state is enacting an upper payment limit for PRTFs. The federal match for Medicaid is in all shapes and sizes. We are the lowest in the country at a 50-50 match. There are states that are 70-30 matches. And so we're at a disadvantage there as far as what the outlay is, whether it's done through general funds, state matching funds, or whether it's done through supplemental payments. In this particular realm, I don't think there are very many states that have enacted anything like that. We're kind of on the cutting edge. We're out in front on this to help our PRTFs.
Okay, further questions for Mr. Bully? Seeing none, go ahead, ma'am.
Chairman Baldwin, Senators, St. Joseph Children's Home is a nonprofit organization that has been serving Wyoming children and families for over 92 years. We currently are a psychiatric residential treatment facility that is licensed for 62 beds. We serve severely emotionally disturbed children ages 6 to 17. We are currently the only in-state provider that serves children under the age of 12 and currently serves boys. A third of our current population are elementary school aged children. We receive referrals through the juvenile court system, children who may be delinquent or chins or abused and neglected. We also receive referrals from private placements, from parents and guardians who, despite their heroic efforts, are in need of professional help and oftentimes are assisted to seek our services through DFS. We also receive referrals from our local school systems who, have done everything they can to try to serve these children in their public schools, but need assistance, further assistance. The average age at St. Joseph's is 12. The average length of stay is about 6 months. The average child at St. Joseph's has had 4 to 5 previous out-of-home placements, such as foster homes, group homes, hospitalization, and even jail. At-home and community-based services have been exhausted for youth who are referred to PRTF level of care. Children entering St. Joseph's have experienced significant trauma. Many of them have been victims of domestic violence and abuse. Many of them have lost a parent due to death or incarceration. Some of them come from homes that have been plagued by substance use and abuse. Through no fault of their own, these children exhibit severe emotional disturbance and distress and often act out at home and at school. They experience paralyzing fear and uncontrollable anger. They often act out violently upon others as well as themselves. Many of them suffer from depression and anxiety, and some of them have tried to take their own life. There are currently 42 children residing at St. Joseph's, all from the state of Wyoming. Staffing challenges, as Mr. Bully has said, has impacted our ability to fully utilize our 62 beds. And yet the need for our services has increased dramatically. We maintain a wait list of children who have been approved for admission who are waiting a bed. And I assure you the phone continues to ring every single day. These children, as Mr. Bully said, have been languishing in detention centers, hospitals, and other facilities that are not able to care for their psychiatric and therapeutic needs. When we're fully staffed, we have 100 full-time employees at St. Joseph's. In addition to providing a very structured 24-hour supervised living setting, youth in our care receive psychiatric services and medication management from a board-certified child and adolescent psychiatrist. They also receive intensive psychotherapy services, including individual and group therapy services. And for those fortunate to have family members and guardians as a part of their care team, they receive family therapy and parent training as a part of their treatment plan. We also operate a fully accredited K-12 school year-round with highly qualified teachers and aides who provide full academic instruction for our children so they do not find themselves behind when they return to home. Almost 75% of the children in our care are Wyoming Medicaid eligible youth. Wyoming Medicaid pays us a per diem for board care and treatment services, but this per diem does not come close to covering our costs. In order to retain our current employees, we've had to increase our wages by 24% in the last 2 years. We have recently lost several staff members to higher paying, less stressful positions in the for-profit market. And therefore, we're unable to maintain the wages that they're able to obtain in the private market. The staff we employ work with the most fragile and the most difficult population in the state. Like most American households, our operating costs, including food, utilities, insurance, fuel, have also increased by almost 8% over the last year. Access to quality, timely mental health services is essential to children to grow up healthy and reach their full potential. If we do not invest in treatment for these children, they will end up becoming more difficult and more expensive as they end up in hospitals, detention centers, and even our prison system. This is a solution that would help us to narrow the gap between our costs and reimbursement with no to little impact on the state general fund. In my opinion, it is a win for the state of Wyoming and a win for children and families of Wyoming. And I will stand for any questions. Thank you.
Questions, committee? Seeing none, thank you. Oh, you got one. Senator Dockstader.
You got 60 plus, Mr. Chairman, you got 60 plus patients there now, clients. How long do you keep them? And what would you estimate that you spend on one individual there?
Go ahead.
Chairman Baldwin, Senator Dockstader, the average length of stay right now is 6 months. Oftentimes length of stay is dependent a little bit on payer sources. They oftentimes can dictate length of stay. Right now, the average cost for an annual per year per kid would be, this is extremely expensive, $150,000 a year.
Further questions, committee? Nope. Senator Barlow.
Thank you, Mr. Chairman. Thank you for your testimony and the work that you and your team do. Payer mix, public versus private. What is that? What is that? Just 30-70, public, private? I mean, just give me an estimate. Thank you.
Go ahead.
Chairman Baldwin, Senator Barlow, as about 75% of our population is our Wyoming Medicaid youth, I would say that the 25% would be either private insurance or another payer source.
It's a pretty good guess. Senator Hutchins.
Thank you, Mr. Chair. Mrs. Meyer, a question on the 6 months. That's the average stay. Is 6 months enough?
Go ahead.
Chairman Baldwin, Senator Hutchins, certainly length of stay is individualized, right? We can have some children who need less time. We have some children that need more time. On average, I would say, no, it's not quite enough. Again, oftentimes our length of stay is sometimes highly influenced by payer sources. We certainly want to do what's best and what's right for children. Unfortunately, as we've seen length of stay being pressured downward, we have also seen an increase in readmissions to our facility. So again, that pressure for length of stay is oftentimes driven, unfortunately, by payer sources.
Follow up, go ahead.
Thank you, Mr. Chair. Ma'am, when you talk about the length of stay influenced by payer sources, where do you send the child when payer source dries up or 6 months or whatever? What happens to that child?
Chairman Baldwin, Senator Hutchings, there's several answers to that question. Our treatment team will not necessarily kick a kid out when a payer source has ceased to continue to cover treatment. We do have a fund that provides scholarships for continued care in our facility, as long as the treatment team determines that the child still could benefit from our services. For children who have successfully completed the program, many of them may return to their home communities, either maybe to a foster home, some of them to their own families, to relative placements. Some of them who are not, maybe the family isn't quite ready for them to return home, they may go down to a step-down facility, such as a residential treatment home. For example, you might have one in Laramie Cathedral Home for Children, Yes House in Gillette. They may go to a group home while they continue to work to reintegrate back into their communities and into their families. I hope that answers your question.
It did. Thank you very much. One more.
One more.
I'm just wondering, because you seem to work so fast, what kind of program are you using that's helping these severely traumatized kids, mental issues? What are you doing that maybe you can share with the school system, homes, churches, whatever, that they could possibly use to help these children as well?
Chairman Baldwin, Senator Hutchings, we use a number of different modalities as well as behavior modification programs, and have done and are more than willing to work with local school districts or anyone that would be interested in learning more about our program and our approaches. So to be more specific, we use the psychoeducational model, which is a Boys Town model. Boys Town is located in Omaha, or Lincoln, excuse me. We also use several therapeutic modalities, including dialectical behavioral therapy, EMDR, trauma-informed care practices, CBT, and a whole host of other modalities, because every child is unique, and so not every approach is going to work the same. So we have quite a large toolbox of tools that we utilize to assist these children and families.
Okay. Go ahead, sir.
Thank you, Chairman Baldwin, members of the committee. I got off easy because I could just say what Rhonda said. Our PRTF runs very similarly, but at Wyoming Behavioral Institute, we are the only inpatient psychiatric hospital in the state. So our level of service starts differently in that we run an acute level of care for children ages 6 up through geriatric patients in different spectrums. And then we also operate a PRTF program in addition to the acute phase of care, offering all of the same different programmatic offerings. There are, we see between 2/3 and 75% of our patients are Wyoming Medicaid patients as well. A couple of just things to note. Not only the legislature but the executive branches for decades worked on making sure that there's a continuum of care for youth in this state. Back in the day, there was a state-funded youth treatment center. Actually in Casper, was on the Life Steps campus. That closed in the mid-90s, which left a larger void within that service population. Then subsequent to that, several other psychiatric residential treatment facilities gave up those licenses, leaving only St. Joseph's and Wyoming Behavioral Institute as the only 2 PRTF providers in the state of Wyoming. Our services are primarily either private insurance or Medicaid funded patients that we see in our facilities. And when we look back to the state budget cuts in 2021, the rates that the Medicaid rate was reduced to sort of sent us back to the 2011 levels. Some of those have been restored, but our costs continue to go up. Costs for employees continue to go up. Our current PRTF runs, we have a 30-bed unit, and ours is focused on female adolescents 12 to 17 years of age. Everything else is sort of what Rhonda said, so I would stand for any questions. Yeah.
Questions, committee? Senator Dockstader.
Mr. Phillips, quite a long time ago, through some ecclesiastical responsibilities, we had to send someone your way. And turned out to be a much more difficult situation than we anticipated. A lot of costs. There was no money to pay for it. We looked everywhere. What do you do in situations like that?
Chairman Baldwin, Senator Dockstader, if I may, just as a follow-up, was that for a residential treatment program or for an acute treatment program?
Mr. Chairman, I don't know the difference.
Okay, we would take the patient and stabilize the patient as best we could, and then we would try to find, when it's appropriate, downstream services for that patient to reintegrate back into the community. So if it was an acute stay, our acute stay for children and adolescents averages 7 to 10 days to get them over their acute phase. And then they could either, at that point, go into a group home, return back to school, do an intensive outpatient program or something like that. If it's a residential stay, it's a longer period of stay. And then we would, certainly try to manage through their process the best that we could, and then try to get them to the appropriate next level of care.
So, Mr. Chairman, if there is no money, what do you do?
Chairman Baldwin, Senator Dockstader, there's no money, right? I mean, that's that you have to take care of the patient. So.
All right, thank you.
Follow-up questions? Seeing none. A follow-up. Representative Bowling. Eric.
Don't call me that, Mr. Chairman. Mr. Chairman, committee members, just in conclusion, I just had a couple of quick points to make. This is absolutely in no way Medicaid expansion, and it shouldn't even be suggested that it is. These are already Medicaid patients. There isn't funding to take care of them. And so this is an ability to take care of those patients at the right level. The other two things I would just say is I've spent quite a bit of time in WBI walking the halls with Mike and seeing their facility. And I think this committee actually took a tour of Wyoming Behavioral Institute. Was it last year or 2 years ago? This last summer, I actually visited Rhonda and she took me for a tour of St. Joseph's. And I was moved by what both of these facilities do. And I think it would be great for this committee to go and see the mission that they really perform there. Seeing those children and seeing the services that are provided in both of these facilities, it's humbling. They provide school, they provide activities, they provide spiritual counsel. They take such great care of them. And if we can get these kids better, they're going to go home, they're going to become productive citizens, they're going to live a productive life. If we don't find a way to take care of them, they're just going to keep going through the system time after time. This is a way for us to help ourselves. There's no cost to the general fund in this. We're even covering the position within the Department of Health through assessing ourselves and paying for that position. So we would just ask that for your favorable consideration and passing this legislation. Thank you.
I would vote that the committee be admitted there for a month in each of these facilities. Thank you very much for presentation. Allie and Joseph, anything to add to this conversation? Again, Allie's first.
Chairman and committee members, we just stand for questions if anybody wants to dig into anything legal. I think as Joe has pointed out before, we can answer any nuanced questions you want about the Medicaid program or anything like that. But I think the department has covered it really well, but we're here for questions.
Any questions for the attorney experts committee? Seeing none, looks like you guys got off the hook. Thank you very much for appearing. Okay. Anyone in the audience here wish to testify to the bill? Go ahead.
Good morning, Mr. Chairman. Members of the committee, Andy Somerville, Executive Director for the Wyoming Association of Mental Health and Substance Abuse Center. And Mr. Chairman, just very briefly, WAMSAC strongly supports this bill on behalf of our member, St. Joe's and WBI. They are incredibly important members of the continuum of care. And simply put, the larger continuum, including the community mental health centers, cannot do our jobs without these resources. So we would ask for your support today, and I'm happy to stand for any questions.
Questions, committee? Thank you very much. Anyone else in the audience wish to speak to this bill? Seeing none. Come up to the table, Representative. Is there anyone? Oh, there was, no, I think the only ones online for this bill have already spoken.
Mr.
Okay, We'll
Chairman, I
close
don't
this-
see any
oh.
hands up online, so no hands up online.
okay.
Mr.
No,
Chairman.
no hands up. Nobody put their hands up. Representative Larson, go ahead.
Thank you, Mr. Chairman. I think that there's a few things that I'd just like to add to help the committee perhaps understand a little bit better. Mr. Phillips pointed out that we have had some cuts in 21, 22. Some have been restored. There's a 2.5% Medicaid reimbursement cut that we made as part of the step 2 that in this year's budget bill is being restored for the community providers, but is not being restored to the rest of the providers. We need to consider that, getting that done next year. Director Johansson said that they're making applications to put this in place. I just want to remind everybody that the private hospital upper payment limit is in place. We're just amending it to accommodate the PRTF. As St. Joe's and WBI were up here, Mrs. Meyer and Mr. Phillips, it's important to note that we rebased them a little bit last year, but they hadn't been rebased since 2012. And so when we look at those funds for taking care of these kids, their reimbursement had not been rebased. And we kind of put a Band-Aid on that last year. Again, to your committee, Mr. Chairman, might be something worthy of looking at. And unfortunately, that Senator Dockstader left because he asked the big question, which is, so what if this is really a difficult question? And the very honest answer is we have times when nobody will take these kids. Nobody, in state or out of state. And so we'll have kids sitting in a county jail or in an emergency room. It is one of the gaps in our policies of the state that we really need to fix. What's the role of state government in those situations? We don't have anything to do with that. Our PRTFs, our RTCs, our group homes and crisis beds are a critical component of that, but we do not have a policy for how we deal with all of that. So Senator Dockstader I was just noting in your example, sometimes we have these kids, nobody will take them. We can't get them done in state. We can't get them done out of state. So it's something that we and this committee really need to fix to get this policy into place. Right now, WBI doesn't take any adolescent boys unless that's changed the last couple of months. So, and that's largely because of reimbursement. St. Joe's does. So what do you do with these adolescent boys? They're higher, they're more difficult, a lot of reasons that we understand. Take adolescent girls. And so we still have some gaps. This will go a long way in helping to fill in and put people into place. But when you've got an adolescent that requires 2-to-1 oversight, you've got to be able to, you have to have the funds to do that. So this is a large step forward, and I think we just still have a lot of work to do on that as policy for this state. Thank you, Mr. Chairman.
Thank you, sir. Just as a editorial here for those in the audience, both online and here, that the time did open up to submit interval topics for the interim committees. Talking about rebasing, I think that's a very appropriate discussion for the interim. So that in mind, there's an online source. You can put in online suggestions for interim topics. That was my editorial for the day. We're closed to public comment. Committee comments, questions, suggested amendments. Move bill is moved. Stand second. Moved by Barlow, second by Dockstader. Comments committee. Seeing none, we have a very quiet committee. Senator Bouchard.
Mr. Chairman, one of the main things I heard were that we were doing this in a footnote. And so I kind of see this as going into rulemaking in the Department of Health and away from the legislature. So, I mean, isn't that what's happening here?
and I would partially answer that. That's really not what's happening. What we're doing is providing authority for the Department of Health to go to CMS and pursue this program. We're not making any rules. We're not making anything. We're just providing them an opportunity to go pursue this funding and pursue this program that's already in place in the private hospitals, almost to be in place in EMS, already in place in nursing homes. So I believe that's what we're really doing here. Go comment, Representative Larson.
Thank you, Mr. Chairman. Senator Bouchard, the footnote issue is something that we're trying to clean up. When we originally got the private hospital UPL done in 2016, the requirement was they had to go back annually. We anticipated that they would have to go back annually. And so the language of that enacting footnote required every year this footnote to be placed in there. CMS doesn't require it. They're fine with it. We just have to have some language in there that says that it's been satisfied, so we can put this one into the green books like we have all of the others. Nobody's making that requirement except for something we put on ourselves. So that's more of a cleanup thing. The rest of this is not authorized by footnote. We hope to have it authorized by the green book.
Further comments, questions? Let's take the vote on this one, please.
Thank you, Mr. Chairman. House Bill 81, hospital supplement payments. Senator Barlow.
Aye.
Senator Bouchard. Senator Dockstader.
Aye.
Senator Hutchings.
Aye.
And Chairman Baldwin.
Aye.
Sir, we have 4 ayes and 1 no.
Senate File 81 has passed committee. Committee, I'm going to run across the hall. Senator Barlow, would you be interested in running that one on the floor as a committee bill, sir?
I'd be glad to.
Yeah, no pressure. Okay. So you can get with Representative Larson for bullet points, whatever you need. Committee, that brings us to our next bill, and I'm going to run across the hall. Representative sitting in the back of the room trying to hide. Come on up. Yeah, you're looking at me. Yes. We're going to hear House Bill 119, medical prescriptions off-label purposes. You know, we've started this. We're going to complete this. My goal is to complete this by 9 a.m.
By 9?
By 9. You've got 1 hour.
Okay.
You can do it faster if you
So,
want.
Mr. Chairman, we opened up with a presentation. Where would you like to go?
Let's start. I believe we had the 4 people at the table. We had, yeah, the Board of Medicine was about to testify. Let's go ahead and hear theirs, and then you can take it wherever you need from there. So let's bring Mr. Blondebust up first, please.
Representative Penn doesn't need to sit there.
Yeah. Representative Penn, any way you'd like to start us off? Go ahead and introduce yourself one more time.
Thank you, Mr. Chairman. I'm Representative Sarah Penn, District 33, House District 33. At this point, I don't think I have anything further to add. Just in interest of time, I'll let people speak, and then maybe if there's any clarifying statements at the end, I'll speak at the end if that's okay.
Mr. Chairman, Representative, do you want to, because it has been 3 days, do you want to highlight anything before we jump into the testimony?
She's thinking deeply.
I think I'll just try to clean up at the end and
Thank
see what else gets said today, see if there's
And
anything.
committee, you would note you have several handouts that came through today concerning this bill, which may be a benefit to look at. I know at least part of them are from Board of Medicine, and there's one from a doctor, and there's several other things. So with that, I'm going to disappear for a few moments. Senator Dockstader, take the wheel, sir. Go ahead.
Go ahead.
There we go. Mr. Chairman, members of the committee, my name is Kevin Bonenblust. I'm the Executive Director of the State Board of Medicine. It licenses and regulates physicians, that is MDs and DOs, and also physician assistants. And just to answer a question that was asked in the previous hearing, our previous meeting on this bill, psychiatrists are physicians, they are MDs or DOs. That's separate from psychologists who are either PsyD or PhD. And so we regulate psychiatrists. Psychologists are regulated by the Board of Psychology. So just so we kind of know who's in which pew in the church, so to speak. Mr. Chairman, what I testified to in the other chamber was basically, in a lot of ways, this is a solution looking for a problem. And I would direct you to the whole concept that
there is nothing in the Medical Practice Act that has ever barred off-label prescribing. As you heard a few days ago, at least 20% of all prescriptions, perhaps more, are off-label. And it can range from what the treatments that were used for COVID to use of birth control medications to control acne, use of ketamine, which is more of an anesthetic, as a treatment for depression. And the list can kind of go on and on and on. So, and I can tell you this, that there has not been, in my tenure at least, a prosecution, much less a license action, strictly for off-label prescribing. That alone is not a violation of the act. The board cannot discipline that. So when you look at the bill and you look at on page 4, starting with subsection A on line 4, running through the end of the sentence on line 13, that's basically codifying what, if you will, isn't already happening, which is there aren't prosecutions going on. If you want to codify this, that's great. It's not going to change the landscape on that at all. What I would note, though, is that, and it was pointed out several times, the word solely on line 8. And that's really where the rub comes in, is, because there's not a prohibition on off-label prescribing, there's not going to be a prosecution for that. But there are other things that come into play in that second sentence in 403, starting with the words any action on line 13 and running through the remainder of the paragraph on line 18. And what this reads to do is it says, if a prescriber does anything while they're prescribing off-label, then that cannot be considered unprofessional conduct. Fair enough, except as I sent to the committee, for better or worse, the Medical Practice Act uses the term unprofessional conduct to cover a lot of things. And I gave you a list because it's lengthy. Under section 402 of the Medical Practice Act, sub A, Romanet 27, things like willful or careless disregard for the patient's health, safety, or welfare, engaging in conduct that's likely to deceive or defraud the public, intentional falsification or fraudulent alteration of a healthcare record, failing to prepare legible and complete medical records. All these things on down through this list, improperly terminating the physician-patient relationship, intentionally or negligently releasing or disclosing confidential patient information. All those things fall under that umbrella of unprofessional conduct. And so in saying then in that second sentence of section 403, that any action you take while you're prescribing off-label is not unprofessional conduct, all of these offenses come off the table as well. Because what'll happen is somebody can negligently release the patient information. Now, that might be a HIPAA violation or things like that, but it's not a license action now because it's not unprofessional conduct. So my suggestion to you is this, that even if you feel you need to move on this bill, move forward, I understand. My strong recommendation to make sure you're not taking all of these potential violations off the table and perhaps allowing a bad actor to do something and then say, oh, I was off-label prescribing, can't touch me. I would recommend that you consider striking from line 13, the last two words, any action.
Repeat your page again for those listening.
Yeah, yes, sir, Mr. Chairman. On page 4 and starting on line 13, striking with the words any action and then through the remainder of the paragraph. That preserves the ability to prescribe off-label and says the board can't prosecute it solely for that, which is what the intent is here, I believe. But it doesn't take those other offenses off the table so that you have to be a good actor while you're prescribing off-label. That would be my suggestion to you. One other point is then subsection B, which starts on line 20 of page 4, it goes beyond prescribing. It says, and I love this term, notwithstanding any law to the contrary, any recommendation, prescription, use, or opinion of a prescriber or pharmacist related to medical treatment for COVID-19 is considered to be not unprofessional conduct. Okay, first off, that goes beyond prescribing, obviously. But second, we haven't had a licensed prosecution related to COVID-19. There hasn't been one. There's nothing on the horizon. You can pass this, that's fine. But just understand that's where you're at. The last thing I would draw your attention to is at the start of section 403A. So it's again, page 4, line 4. There's that infamous phrase again, notwithstanding any law to the contrary. And what that basically says is despite any other law in the books, the board can't take an action against somebody solely for prescribing off-label. So that means any other statute out there, any other regulation, anything, this trumps that. Fair enough. But understand that there are going to be times that there are going to be things prescribed off-label that you may be trying to address elsewhere. An example I was given was methotrexate, which is generally used as an anti-cancer medication. It's also prescribed off-label for rheumatoid arthritis. Fair enough. But it's also used in conjunction with one of the 4, I'm sorry, I don't recall which of the 4 medications that other legislation in this session is looking to outlaw for the use of inducing abortion. So that methotrexate supports that. And then I did a little research, and it didn't take long, thanks to Mr. Google. And I found that there was a study that said, okay, methotrexate and that medication have about 88% success rate, if you will, in inducing abortion. Methotrexate by itself has about an 80%. So now if we're talking about notwithstanding any other law to the contrary, you could prescribe off-label. Arguably, a physician could say, Mrs. Smith, I understand you've got rheumatoid arthritis. I'm going to prescribe this methotrexate for you, and could be using it to actually induce an abortion. That's not going to be violating of this other legislation it's going through right now. And it's going to run up against just the regular statute that says, you know, you're not supposed to do what we have with the trigger law right now. So I think that this is sort of opening Pandora's box in a way. I think there's going to be some unintended consequences. Can I tell you what they all are? No. But I want you to be aware that that language, notwithstanding any law to the contrary, that's throwing down the ace right there.
Director, just for clarification, the only amendment then on that you're speaking of right now on page 4, line 4 is notwithstanding any law, right?
Mr. Chairman, I'm not speaking to whether that should or should not be stricken. That's going to be the committee's prerogative. If you want to make it the ultimate law, then you leave that language in. So that's really the committee's choice. My suggestion is just beginning on line 13, the last 2 words, any action, and striking through all of line 18 all the way down, so that you're not saying, oh, by the way, if you're prescribing off-label, you don't have to keep good records. You don't have to give records to your patient. The board can't touch you for those things. So that's, if there's going to be any changes, I would recommend that be the change to the bill.
Break for a moment. Committee, you clear on that? Any questions? Go ahead, Director.
Okay. Mr. Chairman, with that, I know you've got a full slate otherwise, and you've heard a lot on this bill, and I suspect you'll hear more. So I'll be happy to answer questions with whatever background information you want from the Board of Medicine, but otherwise, I thank you for your attention.
Thank you. I have a question.
Yes, sir.
You say there's been no prosecution or anything like that. What would you say to providers who take an approach to prescribe these medications on informed consent? What would be your response to that?
Mr. Chairman, informed consent should always be involved in medical care, regardless of what you're doing, whether it's on-label, off-label, if you're not prescribing at all, whatever. Certainly informed consent helps, and actually informed consent is one of the items that's under unprofessional conduct. Now, this was amended, the last part in that second sentence, which I'm suggesting you strike, but still, even at that, informed consent should always be an element of it. So regardless of what's happening in medicine, that's an expectation. I don't know if that answers your question or.
Thank you, sort of. Thank you.
Yeah.
Appreciate it. Any other questions for our director, committee? All right, Director, thank you.
Thank you.
Anybody else would like to testify? I think we're going with either for or against. Let's just rotate folks up so we can keep it going. Director Boley, did I see your hand go up? Go ahead, come on up. Oh, thank you.
Mr. Chairman, committee members, Eric Boley with Wyoming Hospital Association. We have some issues with this bill. And I think it's interesting that we're relitigating COVID again. But I think our problem here is we're captured in on page 4 in subsection A as employers, and you're going to hear testimony today of providers that maybe lost their jobs. I've never seen legislation that would preclude an employer from being able to create policies and procedures within their organization, allow them to oversee and take care of employee matters. When it comes to this situation and off-label use, we're not against off-label use. And as you've heard testimony for the last 2 days, there's a lot of that takes place. I think what we're worried about is the fact that we really have no remedies here if we have a bad actor. Our facilities meet regularly. They have a committee called Pharmacy and Therapeutics where they go over the different medications that can and cannot be used. It's what builds the formulary for our facilities to keep in our pharmacies. So we would like to be excluded from this if you're going to pass the legislation. And if not, we can't stand in favor of it because as Kevin Bonenblust, as he explained, there's a lot that goes into the language here, and we have got to have the ability to manage our employees and manage what happens in our facilities. Whether or not you hold the provider harmless and give them carte blanche to do whatever they want, if something bad happens, this is going to come back on the employer, and it's going to come back on the deep pockets of the hospitals, the nursing homes that allowed this to take place. And with the language in this bill, we have no remedy. And so we would ask that either we are amended out of this or that this bill doesn't advance forward. Secondly, I don't think this bill is necessary. Like we've already talked about, off-label use has been going on for many, many years, and there's many uses for different types of medication that have nothing to do with their diagnoses. I can think of a great example of a really good friend of mine who developed cancer. It metastasized to his spine and into his brain. And the very best oral oncology medication that he could use was that is used for breast cancer. His insurance company wouldn't pay for it. It cost him $25,000 a month, kept him alive for almost 18 months. But there was nothing to preclude him from using that. That's not what that drug is normally used for. There are examples after examples of how this is used. So with that said, I'd stand for any questions.
So clarification, Mr. Bowley, you'd like hospitals exempted out of this?
Mr. Chairman.
Let me ask you a question in regards to what I'm hearing is some are providing it through informed consent or other means. Others, we hear stories where they aren't providing these off-label prescriptions, and it's causing concerns or perhaps loss of job or just absolute refusal. How do we find that balance, Mr. Bowley? What do we do here?
Mr. Chairman, committee members, I think it's a great question. I think that's where medical staff comes in. I think that's where the pharmacy and therapeutic committees come in the facilities. You're also going to hear testimony today of where facilities have said these drugs can't be used and they were snuck in and given to patients inside the facilities, which is against the law and shouldn't be done. And so I really think that this comes down to, in our opinion, comes down to employment law and our ability to manage and work with our staff and our employees.
Mr. Bowley, how many hospitals in your association?
We have, Mr. Chairman, we have 28 hospitals.
Of those 28, who are opposed to this legislation? How many?
Mr. Chairman, I don't think any of us are in favor of it. Our board's taken a pretty strong stance, and it's not that we're against off-label use. We're against legislating this, which we don't think is necessary.
Thank you, Mr. Bowley. Any other questions? Senator Hutchings?
Thank you, Mr. Chair. Mr. Bowley, and this was for the doctor or the board, the guy who presented before. I'm looking at page 4, and I don't see what you guys are seeing. I don't see anything fearful, nefarious, scary, bad actors. It seems as if, and maybe you can answer this, as if the board, all these hospitals are thinking all of a sudden, we're going to have all these doctors who have paid God knows how much money to become a doctor, to practice in Wyoming, just all of a sudden start prescribing off-label drugs because now we can, even though we could before. So what's going on that you think all of a sudden there's going to be all these bad actors? I don't see bad actors not being able to be taken care of on page 4. So tell me what's going on that you guys think all of a sudden these doctors are going to give up all that they've put into this to become a doctor, and now there's some kind of fear that I'm going to just start writing prescriptions just willy-nilly.
Mr. Chairman, Senator Hutchins, I think you answered your own question. This is unnecessary legislation. If we're already doing it, why do we need to do this? But on page 4, in subsection A, it says notwithstanding any law to the contrary, a prescriber or pharmacist shall not face any adverse actions from a healthcare related licensing board or employer. Including disciplinary, so we can't discipline, they can't be fired, they can't lose privileges or credentials solely on the basis.
Wait, let him finish. Oh,
I am reading.
Senator, just let her shake. Thank you.
Solely on the basis that a prescriber prescribed a United States Food and Drug Administration approved prescription drug for off-label use, indication, or a pharmacist dispense a prescription drug prescribed for off-label indications pursuant to a valid prescription order pursuant to this article. And we can amend that out. What if a patient dies? Because something goes wrong in that. What if the prescription for an off-label use has counterindications and it creates a problem? We have no recourse. That family, that patient, they're going to come back against us, and the prescriber, the physician, according to this, is held harmless.
Mr. Bowley, then legal ramifications are your greatest concern here? Legal ramifications?
Well, Mr. Chairman, I believe that we'll see an increase in our malpractice costs for one thing. And then again, like I said, we'll be the ones left holding the bag. We're not against, like I said, we're not against off-label use. I can give you numerous. I just don't think this is necessary. If we want to make this a completely COVID-related bill, let's do that. Let's talk about ivermectin. Let's talk about hydroxychloroquine. Let's talk about remdesivir, whatever we want to do. If we want to pass a legislation right now that takes care of COVID that we believe we're almost done with and that the president has declared will be over in May, let's make this completely about COVID and let's move on.
Thank you. Senator, follow-up?
Yes, thank you, Mr. Chair. You didn't finish the whole section A where it talks about obtaining informed consent from the patient. We passed under the Meade administration a bill called the Right to Try Act.
Mhm.
And I think that falls in this, where a patient has the right and a doctor to try to help a patient when they're in need or possibly a death. So again, when you kept reading, I do not see the fear that you see, and I think codifying your actions will only help you, not hurt you.
Mr. Bowley?
So
Mr.
that's
Bowley?
my question to you. If you really read that section again, maybe you can come up and let us know whether you see it differently.
Mr. Bowley, it did end with a question. Go ahead.
Mr. Chairman, Senator Hutchins, we believe in informed consent. But again, what protections are there if things go awry? That's the question that I have here. We're creating a safe space. It already exists. But this puts the employer in the middle of this, and it removes the person that actually is prescribing. Informed consent is super important. People need to understand that. That doesn't necessarily protect the prescriber, but this bill would.
Thank you, committee.
One more, Mr. Chair.
One more.
One more, the informed consent, the right to try, and we gotta admit it, one for one, we're all gonna die, and we know that. Being able to try is so important. Wouldn't you say, Mr. Boley?
Mr. Boley, that'll be final question here, and then we're going to double check with the committee. Go ahead.
Mr. Chairman, Senator Hutchins, I think that the legislation that was passed a couple of years ago is great legislation. Once again, I want to reiterate, they may decide that they want to try it, but if they do die, there are still ramifications because the family and others are going to look at the entity that allowed it to happen. And I think that we already have what we need in place through current legislation.
Committee, anything else? Senator Bouchard?
Thank you, Mr. Chairman. So a lot of things that you said bad things are going to happen. I think they already happened. We had hospitals that were fired, doctors that were trying to give alternative treatments. I know of one personally that I attended a rally outside of his employer.
You have a question?
Yeah, I'll get to the question, Mr. Chairman. So you said, what if a patient dies? That's what this bill is about, because that is what was going on. We had people dying, told to stay home, wait till it gets bad enough, then go to the hospital. They would die in the hospital. There's no ramification for those people.
Mr. Boley?
Under the current situation, the way it is, that just continues. And I don't hear any solutions of how to fix this problem, except no, let's not pass another bill. And I had a bill that would have handled this specifically.
Let's stay to this bill.
And this bill now does this. So where are the solutions to fix those problems
There's
that we
the
have?
question, Mr. Boley.
Mr. Chairman, Senator Bouchard, I'm aware of the situation you're talking about. It isn't one of the Wyoming hospitals, that situation that you're talking about that took place here in our community. Mr. Chairman, it was a clinic that's owned by an out-of-state hospital. As far as COVID is concerned and what happened over the last 3 years, there was a lot that needed to be figured out, and there were a lot of mistakes that were made on both sides. Listening to Fox News and all the different things that they threw out there early on, there needed to be the ability for medical staffs to meet and discuss the pharmacy and therapeutics to meet and decide what should take place. And I go back again to the situations that you're talking about. That's an employee and employer issue. And those entities, those employers had the right to do what they had. There's legal recourse there. There's lawsuits that can be filed, and they can go back and litigate whether or not that was should have been a firing, or that person should have lost their job.
Thank you, Mr. Boley. Senator Barlow, did you have any?
Thank you, Mr. Chairman. So I was a sponsor of the right to try one, and I can actually go through, there are actually some quite good language in that could have been maybe modeled into this one. So my question is, and I'll ask the sponsor when they come back to the table, is in the original bill, there was an immunity from civil liability. If the employers were included in this bill with immunity from civil liability for off-label prescribing, would that satisfy some of the concern that your organizations may have? Thank you, Mr. Chairman.
Mr. Chairman, Senator Barlow, that was actually one of our suggestions that we made in the House side. And instead of including the employer for the immunity, they just stripped all the immunity out of the bill.
Thank you. Senator Barlow, what's your thoughts on that part, stripping the immunity out?
Mr. Chairman, I think the immunity was stripped out, but it was only immunity for the prescriber or pharmacist. And that was my inquiry, was if that would be another, and we're going to have other folks, I think the immunity, or anyway, there's a liability right now, also in statute is 2 years, I believe, for prescribers and pharmacists. So 2 years, depending on the age of the patient, of course, but 2 years. So my point being is that if liability, and I think that is the issue here, and under employment law, if we're going to disallow them from having any say, do we need to protect them from the adverse actions, and the liability may be associated with that. Thank you, Mr. Chairman.
Thank you. Mr. Boley, thank you. We had the Vice President of the Senate walk in. Mr. Vice President, would you like to say anything? he's involved. Mr. Vice President, would you like to add to this contribution or testimony? Okay, thank you. Just double checking. So state your name and where you're from and proceed.
Chairman and Senators, I'm Dr. Willard Woods.
Would you pull that microphone right to you?
I'm Dr. Willard Woods. Been practicing in Wyoming since 1979. Board certified in OBGYN and have general surgery training, and have done thousands of deliveries and tens of thousands of surgeries, and I've always been a family practitioner, which you have to be in Wyoming. And I've really loved being here and treating the wonderful people of Wyoming. That all ended in November of 21, when I was unexpectedly fired. 3 administrative corporate members came into my office at 4:30 in the afternoon. I still had patients to see. I was double booked for the next 2 to 3 weeks. I had patients clear into February scheduled, and was seeing thousands of people, was the busiest person in the clinic. And they just told me that because I'd been prescribing hydroxychloroquine and ivermectin for COVID successfully, I might add, that I was fired. There were no patient complaints. They wanted me to immediately get my charts done. I could see no more people, not talk to them. They wrote a letter saying I had quit and find another doctor. And I would have never left my patients hanging like that. If I was going to retire, I would have tapered their care off. Patients still had labs to be discussed, x-rays, consultation to be made. A lady with an abnormal pap needed treatment. I could go on and on. But I did not take prescribing these medications simply because someone said they might work. I was very skeptical that an anti-malarial drug like hydroxychloroquine, and later on an anti-parasitic drug like ivermectin, would work against a virus. But after hours and hours of study, looking at the molecular and cellular level, and seeing the results of these studies, hundreds of them now, I was convinced that it would work. And the first patient I tried it on was my own daughter, who did remarkably well. And I got more confidence as time went on, and I saw patients improving. And I would call these people at day 2, day 3, day 6. And if they didn't call me back, I asked them to call me back how they were doing. I would call them. And they all did well. They didn't suffer from this disease like the other people. And they told me that. And they didn't die. 750 patients, and they didn't die. The death rate in the United States is about 1%. So 7 or 8 people did not die because of what I did. And many, many other doctors have done the same and had the same results. These are called observational data or studies. And that's how you learn to prescribe off-label. You repurpose drugs, find out they work, publish that observational data, and then other doctors and providers use it. So, and I could talk for hours about the data that I
appreciate that.
read, and I won't.
Our chairman gave us a 9 a.m.
So
deadline.
I'm going to get to the real crux of the matter.
Find
and
a
that's
concluding
medical
comment
freedom.
here, and then we'll open it up for questions, Doctor. Appreciate you coming. Thank you.
I haven't
Find
finished.
kind of a concluding comment here.
Okay. This is about medical freedom. This is about the doctor-provider-patient relationship that has been blocked by corporations and employers who hold the sword of Damocles over those providers' head, because they know that if they prescribe what they feel is correct and right and maybe life-saving, they are going to lose their livelihood. They are going to lose what they've wanted to do their entire lives because of them doing what I feel and they feel is the right thing. I know that there's a chance this is not going to pass. So think about this situation. These patients were being told when they go into the hospital or clinic with a positive COVID test, okay, I'd love to treat you, but there's really no treatment. Just go home, take Tylenol for the headache or pain or fever, and come back when you get really sick. Or you could tell them, well, I do have these drugs in protocol that we can use, and inform them completely about it. Give them even the websites to go to the meta-analysis on them. And there's a good chance that this is going to be 50 to 85% less chance you're going to die. And it's very cheap and it is risk-free. Remember that. This has no risk. Published data shows people do not die from these drugs. I had been giving these drugs to people for decades, every day, and it's only 5 days you're taking it. So given those two choices, what would you do? As a provider, as believing firmly in taking the Hippocratic Oath, would you say, we can't treat this, there is no treatment? Or would we say, even if there was a 10% chance that this may save your life and it's cheap and it's totally risk-free, what would you do? Well, if you're going to lose your job because you do the right thing, that shouldn't be. Wyoming of all states should not allow medical freedom, should not allow this threat of retaliation for doing the right thing come between the provider and their patient. And that's what's happening here. Non-medical people are making the decision that for some reason these two drugs should not be given. And the worst thing that could happen to you, you're fired. You can't even find malpractice because they'll ask you the question, were you fired by anybody? And when you have to say, yes, I was, that raises your rate sky high. And of course, there's a non-competition clause in my contract that you couldn't practice within 20 miles of the facility of that corporation for a year. Okay? So,
Well, let's open it up for questions now from the committee,
Yeah.
sir. Thank you. Just a personal note, sorry you caught up in all the confusion of COVID. What a couple of years, wasn't it? Committee, go ahead.
Thank you, Mr. Chair. Thank you, Senator Barlow. One of the things I'm hearing, and I think it's important for us to note, is doctors are concerned. They're have great care for their patients. They desire to help, not to hurt. And we hear this a lot in this committee about interfering in a doctor-patient relationship. But in this case, wouldn't you agree, we are wanting to be in your business because you guys want the right to save lives, not the right to take lives. Is that true?
Dr. Woods?
absolutely. That's really what it's all about.
Thank you.
All right, members of the committee. Senator Bouchard?
Thank you, Mr. Chairman. Thank you, Doctor, for coming, because I don't know you, I've never talked to you, but I've heard your story from several doctors around the state. So thank you for coming.
Thank you for letting me come here.
Thank you, Mr. Chairman. Dr. Woods, thank you very much. So my inquiry, and this goes to your, I think one of the last points you made was regarding the medical malpractice. Do you think that the removal of the civil immunity liability from the previous bill, should that be placed back in there so to provide you immunity but it should also be extended to the employer, your employer, so that your actions do not put them under a liability?
Dr. Woods?
Thank you, Mr. Chairman.
You know, I don't know the specifics of the laws there. All I can say is that there should not be any retaliation against doctors that do this. Why is it that hospitals don't want these two drugs? I wonder why that is. 50 years of being a doctor, I can't, for my life, figure out why they want something totally safe and cheap. The first time I prescribed ivermectin, I had the patient call me back and see how much it was. $18.75. This drug is 10 cents over the counter in some countries. 80 countries use this drug routinely, and 20 countries use it as standard of care. We are one of the worst countries in treating COVID. For 100,000 people, 350 plus die. In India, a third world country with far less better care than we have, they have 39 people per 100,000 die. 10 times better care. And what's the difference? They use hydroxychloroquine and ivermectin, and we don't.
Senator, did you get your community question answered in there? Okay,
Did I not?
that's all right. We're okay. Anything else? I have a question, Dr. Woods. And I'm sorry for all that you went through. What if we had a bill that was specific to those two medications, like the Hospital Association suggested? What would you think about that?
You know, it really shouldn't be just about these two drugs. It really shouldn't. You know, it could be the same thing about any treatment, any procedure. When non-medical people are making decisions on medical things, that's a problem. And you know, there's a lot of examples of that I could cite. You know, a lot of you people here probably have been on off-label drugs yourselves. You know, over 20% are prescribed that way. But there was such a concerted effort to demonize these drugs. I just don't understand that. Was it that it was keeping people out of the hospital? I really think that's part of it. You know, but I hate to say that it's a monetary thing, but I don't know what else would have caused this.
Thank you for coming to testify. Personal thank you for treating all the probably thousands of people you've treated over the years. You remind me of an old country doc out west that just was a difference in everybody's lives. No doubt you did the same in your area. Thank you.
Thank you.
All right. Anybody else would like to testify? Thank you, Doctor. Yeah, let's line some more up here. Let's, our chairman's choice is to go the fours over there and the against over there. You're a four. You're an against? Oh, you're sitting in the wrong place.
That's okay.
We'll excuse you this time. Go ahead.
All right. Thank you, Mr. Chair, members of the committee. Tony Deckleber with the Wyoming Nurses Association, and we stand in opposition to this bill for the reasons that have been already stated, that it's unnecessary. Advanced practice nurses are also prescribers, along with the other people that are mentioned in the bill. So it's not just doctors, it's anybody that prescribes medication. And I just to share a couple of things with you. I have been a clinician. I'm an RN, so I've been a clinician. I've been an administrator. I'm an educator. I own my own business. And the very first thing, whenever we would, start a job, is you meet for the first couple of days and you go over all the policies and procedures of your employer. And then when I was an administrator, it was our job to review the policies and procedures of our institution. My own business, I work as a bit of a franchise, and there is a policy and procedure that I must follow. And if I don't follow that, I can stand to lose my business, okay? Because that's the rule. And we all function under rules. Even you as legislators met for a couple of days to establish rules. And if there is a violation of those rules, then there are consequences. So I can tell you that I have a nurse friend who is an advanced practice nurse, highly trained. She was trained in a very specific procedure. She worked at the VA, but she was not allowed to do that procedure because the policy of the facility prohibited that. And if she chose to do that procedure because she felt like that's what she wanted to do, she stands to suffer the consequences of violating the policy of the facility. When people are in private practice, they can do whatever they want. But when you work for someone, you must follow their rules and follow their policy. And so this, when it says that a prescriber cannot be disciplined solely on this particular action, if that action violates the policy of the company that they're working for, they have no recourse. They can just let them do that. I've been subpoenaed to testify in a malpractice case. And when the attorneys were questioning me, the question I got was, what was the policy of your facility? I was sued for wrongful termination of an employee. And the question was, what was the policy of your facility? And in both cases, I followed the policy and I won. I was testifying on behalf of a doctor who won the lawsuit, and then testifying on behalf of myself for the wrongful termination, but I followed our own policy. So I won that case also. So I just think that it's unnecessary because prescribers are already allowed to do this. And unfortunately, that section where it talks about that there's no recourse if someone breaks the rule, then we can't support this.
Thank you. Committee questions? Okay, thank you.
Thank you.
Sir, would you state your name and where you're from?
Mr. Chairman, members of the committee, my name is Gary Brown. I'm a citizen of Cheyenne, Wyoming.
Thank you. Mr. Brown, go ahead.
I come in favor of this bill. My doctor here in Cheyenne was let go from a facility because he was prescribing medication that they did not want prescribed. And I heard it mentioned earlier that there was a clinic here in town that was owned by an out-of-state entity, and that would not apply. I believe that our laws, if a clinic comes in from another state, they would have to follow our laws. And so I just feel that this doctor was let go unnecessarily. He was saving lives. His patients were not even being put into the hospital, and yet the clinic was unhappy about that. And I agree with Senator Hutchinson. Where are all these bad actors going to come from all of a sudden? I just don't believe that they're just going to pop up just because of this bill. Thank you.
Thank you, Mr. Brown. Questions for Mr. Brown? All right, thank you, sir. Go ahead. Name and title.
Mr. Chairman, members of the committee, Sheila Bush with the Wyoming Medical Society. We stand in opposition of this bill for a variety of reasons that I'll try to be brief with. Many of them have already been discussed at length. We believe this jeopardizes patient safety. It fractures the rules and the expectations within medicine. It carves out one area and makes it different than the rest. We think that that's a problem. It removes an important mechanism for our medical community to police itself. Right now, the public puts a great deal of faith in their medical providers, and medical providers also have to put that same level of faith in each other. And part of that system rests on their ability to police themselves. We don't put a lot of rules in statute specifically. A lot happens through the rules of the Board of Medicine and the mechanism for physicians to be able to file complaints against each other and go through that process that way. This bill, if passed, creates a real problem in that process. We think it sets a very dangerous precedent. This is an overreaction to a very specific situation. And we would echo the comments of the Hospital Association. If we wanted to, if it's strongly desired to have this bill come out, it should be specific to the medications being mentioned. As long as this is a broad, covering all prescriptions off label, which again is 20 to 30% of prescriptions are prescribed off label, it stops the ability for medicine to advance and again, police itself. For example, in the early 2000s, I believe it was, there were 18 million prescriptions written for an off-label use of fenfluramine. It's a Schedule 4, so would still be part of this bill. It was prescribed for weight loss, and that was not its labeled purpose. They later discovered that thousands of people suffered from heart valve damage from that. If we interfere and we intervene and we say we're going to carve out this one side of medicine and leave them harmless, take away all the mechanisms to police that for a very specific set of medications today, we will live to regret it. I believe that we should look at policy decisions today and think 15, 20 years down the line, when the emotions have cooled, will we have done the right thing? Is this a policy that should apply universally to all medications when prescribed off-label? If the concern today is a very emotional one about those specific medications, then that's the conversation that we should be having, and we should decide if that's the right policy for those medications. But to do this universally along the line of all medications when prescribed, off-label, I think is very dangerous. We don't think this fixes anything. We don't see a problem. In anticipation of the question I'm often asked, and in conclusion, I'll wrap up. The Medical Society establishes policy, as you know, through our board. That board is elected by county physicians. They elect a trustee. That trustee comes to the state board. They debate these policies and form positions, which gives me the guidance of what I need to carry forward here. In addition to that, and specific to this bill, the Medical Society has also developed an online platform by which every single member of our organization across the state can weigh in and give thoughts, can ask the Medical Society to take one policy or another position. And this was put up, our president put this bill on, we call it the wire, and asked every physician member of our Medical Society, do you think we should oppose or support? And unanimously, every member of our Medical Society who engaged on that platform said oppose.
Ms. Bush, guilty of that question that I always ask you. Thank you. I have two questions for you before we turn it over to committee. As I've looked at this, studied it, and read the emails, visited with my own providers, we just see confusion out there. There's some are doing it, some are not. As for my own providers, they said, we've got those two medications covered, informed consent, leave it alone, don't go there. And they're pretty strong about that, even to the point that 3-day weekend at home can end up in the hospital, not over healthcare reasons, but discussing bills. So why is there that confusion out there? Some for, some against.
Mr. Chairman, members of the committee, I hate to speculate. My members are all against, and so I haven't had in-depth conversations with those who support. I think we have a sensitive area in which a handful of prescribers ran afoul with their employers and are very upset about it, and have found a sympathetic ear in the legislature to change the law, to change what happened to them.
Thank you. All part of process. Ms. Bush, two medications, would you be opposed? And I don't even know if we can amend this, and I'd want the chairman in the room to allow just those two medications. Would you be opposed to that?
Mr. Chairman, I would urge caution in doing that. However, if it's a way to make this not so broad, I would rather that than the way the bill is now. Our ultimate wish would be for it to fail committee and not move along in the process. If that's not the desired outcome of the committee, then I think amending to be more specific would be wise, when you juxtapose that with this very broad application across all medications.
Thank you. This is what we're going to do. We have 10 minutes based on the chairman's advice. Any committee questions? We're going to go here, and then we're going to go down to these two, and then back to the sponsor to
Just make one.
just quickly, but I'd like you to do the wrap up if we could.
I just would like to ask if maybe, and I'm not trying to tell you how to run your committee, but I know that there's at least 4 people who are online who were present at the previous day and have rescheduled their lives. So maybe limiting testimony to like 2 minutes, just so we can get through the people.
Or even 1 minute. Questions for Ms. Bush? All right. Minute 30. Oh, she was first. Yeah. Just name and place.
Thank you, Senator Doxter, Chairman, and legislators here, or senators here. My name is Susan Lone. I'm in House District 411. I was here just to make a quick comment in the fact that had I not had a doctor who would prescribe for me those medications, I probably wouldn't be here today. I was at a point where, I would have taken the horse medication, ivermectin, if necessary. My daughter came and took care of me and my husband both. I gave her strict instructions, do not take me to the hospital under any circumstances. I will die at home, but not there. And I'm just grateful for the doctor that stood up and took care of me and brought me through with those medications.
Thank you. Questions?
Thank you.
Mr. Winnie, short and sweet.
Mr. Chairman, Bill Winnie, Sublette County. We're hearing a lot of the word policy, and I would offer you policy schmolicy. What are we talking about here? The relationship between a physician and the patient is intensely personal. And when corporations get in the middle of that, there can be problems. And I submit to you that the policy ought to be what is best for the patient. I come out of the military medical system. You don't have a lot of choices there frequently. We saw some 8,000 people discharged from the military because they didn't want to take the COVID vaccine. My physician recommended against getting inoculated until last August, when he said, well, you know, you're now over 70 and you're in a higher category, so you probably ought to get this particular vaccine. And so I think you need to end up in the position of the physician, and you might think about the Hippocratic Oath, owes his patient his best opinion. Thank you, Mr. Chairman.
Thank
Subject
you.
to your questions.
Questions for Mr. Winnie? And further comment? Let's go to the internet, the Zoom. What do we have?
Mr. Chairman, we have 5 people online with their hands up. Do you want me to
Maybe
admit?
stretching that 10 minutes. Okay, let's have the first one. Can you put them all up at once?
Mr. Chairman, I've admitted Shay Brewer.
Shay Brewer, can you hear us?
I can hear you. Can you hear me?
Yeah, please proceed, Shay. I don't think we have your picture.
Don't know how to activate my.
Yeah, just go ahead and testify. There you go, sir. Go ahead.
There we go. All right. Hi, my name is Shay Brewer. I live in Lander, Wyoming. And I just want to say that it's a miracle that I'm actually here able to testify before you. According to the medical world, I should have died 16 months ago. When I entered the hospital in October of 2021 with COVID-19 symptoms and complications, I had requested they not use remdesivir because it had shown that it was really not effective in COVID treatment and also caused kidney damage. And I was told that this was the accepted protocol and there was no way they could change what was accepted by the experts to be how to treat this. So my voice was silenced in this and my doctor's hands were tied. So in the end, I started dying from kidney failure and was put in a medically induced coma and flown to Salt Lake City with a 2% chance of surviving. And it was there that the doctors decided to step away from the accepted use of remdesivir and protocols and try alternative treatments, and it saved my life in the end. So it's my belief that had doctors not had their hands tied here at my local hospital, my story would have had a different path to follow. Excuse me 1 second. So yeah, I do believe their hands are tied, and if they wanted to try alternative treatments or medicines that were not accepted in their proper uses, which I take off-label prescriptions right now because that don't have their intended uses, but are still used for other reasons. So I just ask you guys to consider to allow the medical in Wyoming and doctors and practitioners to make decisions on alternative medicine uses without being threatened or prosecuted for making these decisions. So I thank you all for hearing my testimony.
Questions for Mr. Brewer? Thank you, Mr. Brewer. Next, please.
Mr. Chairman, I admitted Alicia Lepard.
Alicia Lepard.
Morning.
There you are. Go ahead.
Good morning.
Name and where you're
My
from.
name is Alicia. My name is Alicia Lepard. I live in Gillette, Wyoming. I stand today representing the Wyoming Council for Advanced Practice Nurses. I'm a nurse practitioner, board certified, and actively work in the acute care and emergency care within hospitals, as well as family and geriatric outpatient care. We oppose this bill for several reasons, many of which already been enumerated. That the authority to prescribe medication either on FDA indication or off-label has already been granted to us under all the licenses and certifications therein by the federal government and the state government. We therefore question why this bill must reaffirm our current authorities. Second, our authorization to prescribe and the right to discipline lies under the appropriate state agencies, which grants the licensures, and stripping these boards and the employer of due process negates the rules and regulations that provide for the safety of our Wyoming citizens. Last, I'm just going to briefly touch on the amendment to provide informed consent. Informed consent, by the way, is a very large process, a legal and ethical obligation that is actually has several elements, including not only stating what the benefits might be, but the risks, side effects, and also what happens if no treatment is done. When I looked up ivermectin to write my longer statement, which I will not present here, it took me 120 minutes to look up all the indications by the FDA, attempt to find the off-label indications approved by the U.S. Pharmacopoeia, and then write the statement that these are used for and come up with the adverse effects, including death that could happen and risk to fetus and infants. So that took me 120 minutes to write a statement that I then give to my patients. That has to be given to the patients in a form they understand, and that includes language and the level of the language. So in conclusion, we kind of feel this bill is totally unnecessary in enhancing or changing the scope of practice of healthcare providers with prescriptive authority. It will cause downstream barriers on licensing boards, and additionally, it may cause a reduction in the workforce and access to care by creating an expensive, time-consuming, revenue-reducing documentation burden to Wyoming's healthcare providers. Thank you for your time.
Thank you. Questions for Alicia, committee? Senator Bouchard?
Thank you, Mr. Chairman. Are you aware that ivermectin is a protease?
I am.
Thank you. All right. All right, next person. Thank you, Alicia. Go ahead.
Mr. Chairman, I admitted Leslie Brewer.
Okay, Leslie Brewer, can you hear us? Leslie Brewer.
I'm here. Can you
Okay.
hear me?
Yes, could you turn on your video?
I'm trying to. Let's see. It's not letting me turn my camera on.
Let's go ahead then.
I'm sorry. Good morning, senators and Mr. Chairman. I appreciate you letting me share our story. You heard from my son, Shay, but I also want to share about the experience we had with my husband. My name is Leslie Brewer, and I'm a special ed teacher, and I live in Lander. I'm here to share a story that I really never wanted to go down this path. And like Shay, you already met Shay, but these are real people. We are not committees, and we are not, don't have an agenda, but we want to share our experience. As my son shared in October of 2021, my son, my husband, and I all ended up in the hospital with COVID. From the moment we entered the hospital, we asked them not to follow the set protocol of using remdesivir. By fall of 21, they already were seeing the major damages it did to kidneys. We did ask for alternative treatment. We were not allowed that. We were told that their hands were tied and they had a set protocol they were required to follow. We were not given that right to try, which really concerns me. We ended up, as you know, we were told we couldn't change our protocol, use alternative treatment or off-label medication. And very quickly, both Shay and my husband, Bob, ended up with kidney problems. My son was flown to Salt Lake, and you heard his story, so I won't reiterate that. What he didn't share was he ended up in the hospital for 6.5 months in Salt Lake City due to kidney damage and the ramifications that affected many other systems in his body. Thankfully, he has recovered. He has some long-term issues he's dealing with because of not giving that right to try an alternative medicine. My husband ended up being flown to Bozeman, and they were not willing to stop the remdesivir when he went there. Unfortunately, 6 days later, he passed away, not from COVID, but from kidney damage. What I want to share, probably the biggest shock in this story, is where we live and how the Wyoming narrative did not show itself to be true. Wyoming has a rich history rooted in personal freedoms, independence, and the ability to make our own choices. These ideologies stand on the shoulders of giants, just like you men and women, and you carve a lifestyle that we know and love, and that's why we live here in Wyoming. If you ask any Wyomingite, they'll tell you that they don't want the overreaching government or the powers that be to dictate our state choices. We pride ourselves in that legacy. I do believe our medical teams were silenced. I do believe, as Shay said, their hands were tied in acting on our requests and in our best interest. They were not allowed to try alternative choices in our medical care. And I'm asking you to change those restrictions within Wyoming's medical world without implied or real threats for loss of license or loss of practice, or even their reputation. You're our watchdogs. I'm asking you to protect us and give Wyoming doctors the freedom to give informed consent to their patients, and that their patients' voices not be silenced, and that you would provide that they could provide appropriate treatment that they see fit for their patients. Thank you for giving us the time to share this morning.
Thank you. Questions for Leslie, committee? All right. Next, thank you, Leslie.
Mr. Chairman, I admitted Laura Pearson.
Laura Pearson, please. Can you hear us, Laura?
Hello, Chairman. Yes, can you hear me?
Go ahead. We can see you too.
Hello, Chairman and committee members. My name is Laura Tolliver Pearson. I'm a 6th-generation sheep rancher and school bus driver in Southwest Wyoming. I'm urging a vote of aye on this bill. Our state's doctors, pharmacists, and citizens need to be allowed access to off-label prescriptions without penalty. That's the key here, without penalty, especially if requested by the patient. There were prescriptions, there were several treatments during COVID that worked. Doctors and pharmacists were held hostage, literally having to choose between their job and their oath. And once again, tied to federal money. This simply isn't right. We as citizens need the ability to acquire treatments that work. And yes, doctors that work in offices that accept federal money were told they would lose their job. Other physicians that would prescribe struggled with pharmacies that wouldn't fill the prescription even when it was prescribed for on-label use. Then if a pharmacist would fill the script, the insurance agencies wouldn't cover it, costing citizens hundreds of dollars for medications that cost pennies to make. One of the cheapest, most effective drugs with the least amount of adverse reactions was denied your constituents, either by their doctors or pharmacies. Why? Please don't believe that this isn't happening in Wyoming, because it absolutely is. The people who were saying there wasn't enough evidence for safety on ivermectin and hydroxychloroquine were encouraging or coercing a vaccine which came with a blank package insert. There was conversation in the House committee about notifications of adverse reactions. We weren't informed about adverse reactions of COVID vaccines. Doctors were threatened if they revealed the multiple adverse reactions or if they recommended a patient not get it. No one needed to die. It's pretty sad when citizens have to take it upon themselves to dispense horse paste to our friends and loved ones, even going as far as sneaking treatments in the hospitals because our doctors and pharmacists' hands are tied. Federal money is not more valuable than human life. And as far as patient recourse, what kind of patient recourse do we have in dealing with COVID? Not only the vaccines, but inpatient hospital practices, remdesivir, dehydration, denial of requested treatments, intubation, or death. I'm sorry, but our medical institutions have failed us, and all in the name of money. We need to protect our doctors, pharmacists, and citizens. When medical professionals aren't allowed to offer informed consent and are fear-mongered when prescribing off-label, the patient-doctor relationship is totally compromised. Thank you for listening to my testimony.
Thank you. Questions for Ms. Pearson? No? Okay. Next, thank you for testifying, Ms. Pearson.
Thank you.
Mr. Chairman, I admitted Twyla Brace.
Twyla Brace. Twyla, can you hear us?
I can. Can you hear me?
We can see you. Go ahead.
That's great. Thank you so much. My name is Twyla Brace. I'm president and co-founder of the Citizens Council for Health Freedom. Our organization works nationwide to protect patient and doctor freedom. I'm also a registered nurse who specialized in emergency room nursing. We support HB 119. Ultimately, this bill secures the right of doctors to save lives, not only for COVID, but for the next pandemic and the next FDA-approved drug that FDA wants to prohibit. The FDA law says off-label may not be prohibited, but during COVID, many doctors were prohibited by their hospitals and by government officials, and as a result, patients died. It's interesting that hospitals want to be exempted. The Hospital Association talked about wanting hospitals to manage their employees, but this is actually about controlling the doctors who are their employees and about limiting drugs on the drug formulary. The Times Leader reported in 2021 that physicians at Geisinger, Wyoming Valley Medical Center, quote, refused to administer ivermectin despite requests from the daughter of a Plains Township woman, as the drug was not approved to treat coronavirus by the FDA or by the NIH. Now, Dr. Woods wonders why the concerted effort to stop two very safe and effective drugs, but this may be about profit. Geisinger is part of the Medicare Shared Savings Program, a program that allows hospitals to share in the savings the hospital saves the government, so that if they can control their doctors, they can limit their costs, even if it rations care. There's also much money to be made from treating COVID. An attorney in a Texas lawsuit said hospitals could get $3,200 from an outpatient COVID patient, but for a hospitalized patient, it was well over $100,000, and it was over $400,000 for a ventilated patient. Finally, the Hospital Association said that those terminated can litigate. But on behalf of patients, I must say, how many years would it take and how many patients would have died because those who would actually treat them right were no longer able to do so? So this is your opportunity to protect the freedom of Wyoming physicians and the lives of Wyoming patients. It's your opportunity to protect your constituents from an overreaching federal government and compliant hospitals. Now, before another pandemic arrives and another FDA-approved drug that's not ivermectin is needed. Therefore, I urge the committee to pass HB 119 to protect the physician's right and the pharmacist's right to do the prescribing and do the dispensing without retribution or penalty. Thank you so much.
Thank you, Ms. Brace. Questions for Ms. Brace? Go ahead, Senator Barlow.
Thank you. Thank you, ma'am, for your testimony. So would you approve of reinserting the civil liability that was stricken in the House? And if so, if you would approve of that, or would you think that's acceptable, would you extend that to the employers? Thank you.
Ms. Brace?
Thank you, Mr. Chair and Senator Barlow. We did not have any problem with it before it was taken out in the House, but we did point out the fact that the SOLI was likely to protect at that time. So again, we didn't have any problem with the civil liabilities piece. And, you know, it's possible, I hadn't thought about it until you mentioned it regarding the employers, which is the hospitals, is protecting the hospitals. You know, I don't know that I disagree with doing that. I just say that the hospitals, have been protected for doing what they've done, which is to deny patients the care that they need. They protected from that. It's interesting that they would now like to be protected from what would actually work.
Thank you. Follow up? Okay. All right. Thank you, Ms. Braze. Go ahead. Someone else on the line?
Mr. Chairman, I admitted Jason Caswell.
Jason, before we go to you, for those waiting for House Bill 65988, it's going to be delayed, and I'm not sure that we'll get to House Bill 127. Let's go ahead. Jason?
Yes, sir. Can you hear me?
Yes.
All right. Thank you, Mr. Chairman, members of the committee, for allowing me to speak. I'm Jason Caswell. I'm a board-certified family practitioner that owns Cowboy Concierge Medicine. I'm one of the only clinicians in town that saw acutely ill COVID patients in the outpatient setting and the only one making house calls to infuse antibodies if the patient wanted that therapy. I never claimed to be an expert on COVID, but I'm fairly knowledgeable. And clinicians were prevented from prescribing the medications that we've been talking about. I know that because the patient came right from certain institutions to me to get the medication that they wanted. And my practice philosophy is that it's not my place to supplant a patient's medical autonomy with my paternalism. Just like the venerable Dr. Woods stated, the Hospital Association might be worried about legal ramifications, but this is about power. This is about power to control the clinicians and dictate care for the patient. And, another thing too, is that when it comes to ivermectin and hydroxychloroquine, if we don't have the ability to do that without ramifications, that patient is not going to come back when they deteriorate and get the medication that works the best, which was the monoclonal antibody. So, but I'm keeping it real short. So, thank you so much.
Doctor, any questions? No. Oh, go ahead. Senator Barlow.
Thank you, Dr. Caswell. So are you practicing under the direct primary care model? Thank you.
Yes, yes, sir.
Okay, thank you. Any further questions? All right, thank you. Does that do it? Got everybody?
That's the end of online testimony.
All right. Any further? Let's go back to the original sponsor now. Oh, I think I double checked that. Anybody else? We're running short on time, but it's important that we hear from the prime sponsor.
Thank you, Mr. Chairman. So if I may just clear up a couple of things. There was questions as to why the confusion between these people and these people. Some say it's needed, some say it's not needed. I just want to point back to the article that I brought up last Wednesday, where the Wyoming Medical Board sent out what I consider to be a threat, saying that if you're inappropriately prescribing these medications, then your license may be at risk. My question to that is, whose definition of inappropriate are we using here? That's a very subjective term. What they point to in the article is one, that these medications were being prescribed to family and friends. Well, the situation that we had here was that because there was a chill on this prescribing, providers were seeing around the country that physicians were, and nurse practitioners and PAs were losing their licenses in other states for these practices. They were being threatened. They were losing their jobs over these things. And then we get an issuance from the board in Wyoming that says that these practices could bring you under a condemnation. What that does is it cuts people off. They're not going to prescribe because of the risk to them, to their license, and to their livelihood. And so patients that were seeking these treatments were forced to go to the people that were willing to prescribe them. And thankfully, those people were still out there. And to many, those are considered heroes in Wyoming, because they were still willing to stick their necks out when it was difficult and when it was scary for them to do so, to do the right thing by their patients. And so it ended up being the situation where they were prescribing to family and friends and people that were just coming to them, and maybe they didn't have an established relationship in the facility, because they were trying to save lives. And these medications actually did save lives. This article also says that inappropriate prescribing was that they were being given to patients who weren't symptomatic. We have a term for that in medicine. It's called prophylaxis, and it's very effective. We were looking for prophylaxis in the vaccine. We had prophylaxis in these medications. If people were taking them as prescribed for prophylaxis, they were very effective at preventing people from getting sick. They were also very effective at, if you were to initiate this treatment early on, preventing people from requiring hospitalization. And so this was deemed as being inappropriate, but this should be the standard of care. With COVID, there wasn't a standard of care because, as we discussed last time, nothing was on label. We just didn't have the time, and that's the concern that we come up against in this pandemic type of a scenario, and that's why we can't limit this bill to just hydroxychloroquine and just ivermectin, because what happens next time? Here we are 2 to 3 years after the fact discussing what we should have done. What's going to happen next time? Because it's probably not going to be these 2 specific medications. It's going to be something else. And so we're going to be having this conversation again. The other issue that they say is that it posed supply chain issues. So people who are chronically on these medications, and my own mother is on one of these medications for treatment of dermatomyositis, which is an autoimmune issue. And so they say, well, we have these patients that are already on these medications. If we start using them to save these people's lives, then the ones that are on them for chronic issues, they may have supply chain issues. I had a patient who I sent a prescription for autoimmune use of hydroxychloroquine, who called me a few days later and said, the pharmacy canceled my prescription. So I called them and I said, hey, what's up? And they said, well, it was for COVID. I said, it wasn't for COVID. It was for an autoimmune issue. And they said, oh, well, we didn't know. So the pharmacy canceled that person's prescription. It wasn't a supply chain issue. They had the medication. They just didn't give it to him because they assumed that it was for COVID, even though it wasn't. So we had this situation where we had medications to treat these things, and not only were they not used, but they were blocked. If it was a supply chain issue, a lot of great things happened in this country with COVID. We saw industries overnight change to suddenly they were creating ventilators or change. So suddenly they were creating PPE equipment and producing those things because there was a need. We could have done that with these medications, but we didn't. We blocked them, we suppressed them, and we disciplined those doctors that were willing to prescribe them. That sounds a little bit to me like harassment. In fact, I actually looked up the definition of what harassment is. It says any unwanted behavior that makes a reasonable person feel uncomfortable. When I called the pharmacy about prescribing hydroxychloroquine, I had 12 studies in front of me that showed that it was effective use. It was safe to use for the treatment of COVID. And I called the pharmacy and I said, if I prescribe this medication, will you fill it? And that pharmacist told me, not only will I not fill it, but I will report you to the Wyoming Board of Pharmacy. That made me feel pretty uncomfortable. I felt intimidated by that. What happened with COVID and these medications specifically is that physicians, providers, nurse practitioners, their prescribing rights, or their First Amendment rights were violated. The patient-physician relationship was damaged by those very people who were claiming to want to be upholding it. My next comment is the boards say that they want to still be able to have the control over these physicians. But what happens, who's going to control them? What happens if they're making the wrong decisions? Where's the accountability for them because in my opinion, they created a situation where people were cut off from life-saving treatments. So where's that accountability? House Bill 119 protects the medical freedom of patients to be treated as they desire. It preserves this right in the case of future pandemics. Again, here we are 2 to 3 years later having this conversation. It preserves the integrity of the practice of medicine, the practice. It's not something that's set in stone always. We don't always have these things as standard of care upfront, especially in pandemic type situations. This bill was very, very favorably passed through the House. This bill is in statute in New Hampshire and in Minnesota, and there's other states that are bringing this. So I would ask you to consider the needs of your constituents and consider the needs of the citizens of Wyoming as a whole. And please, let's put the citizens' needs first, because I promise you that your constituents care about this bill. With that, I stand for questions.
Thank you. Questions for the sponsor? Representative Penn, go ahead.
Thank you,
Senator
Mr.
Hutchins.
Chair. Appreciate that. Hearing a lot of testimony about page 4 and how they're saying, the people that testified, that this is going to prevent discipline. I don't see it. I heard one RN say that when you come in, you learn the policies and procedures of the place where you're gonna practice. I heard from Alicia that she will take the time and effort to present a paper to help her patients be properly informed, which was very good. And I think most doctors would do that. So where do you see the lack of any hospital from presenting or disciplining their doctors if they do something wrong? For me, I see it's solely if they prescribe US Food and Drug Administration approved drugs. That's the only thing I'm seeing here. Can you tell us where this lack of discipline would be applied if this bill passed?
Representative Penn.
Thank you, Mr. Chairman. Senator Hutchings. I agree with you. I think that this, some of the concerns brought up go a little far in their concern as to their people's ability to discipline or to bring action if negligence has actually occurred. I think the intent of this bill is to prevent these boards and these facilities to threaten and prevent doctors in situations like what we've been discussing from withholding treatment really from those patients.
Follow-up? Okay. Further questions for Representative Penn? Go ahead, Senator Broussard, or Senator Barlow.
Thank you, Mr. Chairman. So I'll ask you the same question I've asked everyone that came forward. The liability provision that was stripped in the House, if it was restated and included the employer, what would your thoughts be on that? Thank you, Mr. Chairman.
Representative Penn?
Thank you, Mr. Chairman. Senator Barlow. Obviously, you know, I brought the bill with the immunity clause. I don't know for sure how the extending immunity to the facilities itself, I don't know. I mean, I had, prior to you bringing that up, I honestly hadn't considered that much. My concern with that is I just want to make sure that patients still have the ability to have the recourse with the facilities, because a lot of the concerns that have been brought to me from constituents is their complaints are against the facilities themselves. And the facilities were preventing these prescribers from acting as they saw fit. And so if that immunity was extended to them, I guess it could be okay. I don't have 100% answer for you. I apologize.
Follow-up? Okay. Senator Broussard?
Thank you, Mr. Chairman. Well, wouldn't you agree that the immunity clause that Senator Barlow is talking about would be specific to the obstacle that if the doctor did something that they were part of that, they wouldn't get caught up in that. So I think it's a different type of immunity than what we're talking
Representative
about.
Penn?
Thank you, Mr. Chairman. Yes, yeah, I think you're probably right.
Further? Okay. Representative Penn, I have a question. I don't know that we can amend this to go down just to those two medications, but your thoughts on that?
Thank you, Mr. Chairman. I would be opposed to that because the reason that I'm bringing this is because, well, so this is still happening. I had an email from a constituent just last night that said that their parent just in the last few days came down with COVID, was deathly afraid and wouldn't go to the facility or to a hospital because they were afraid they were going to be forced to get an immunization they didn't want. Patients' confidence in medicine has been damaged by this. The point of this bill is not only to address what has happened, but to address what could happen in the future and going forward. And so amending this bill to include only these couple of medications, I think is a step in the wrong direction, because we don't know in the future, next time this may happen, we don't know which medications that's going to be. And it wouldn't protect in those types of situations if we amended to include just a few.
Thank you. All right. Set. Committee, what's your pleasure? Moved by Bouchard, seconded by Hutchins. Let's go over the bill. Page 1. Page 2. Page 3. Page 4. Page 5.
Mr. Chairman?
Go ahead, Senator Bouchard.
I would like to entertain the immunity clause, but I don't think we're ready for it. So if we could, maybe keep the bill moving, and then maybe bring that on the floor. As far as your question about specific drugs, I hate to say this, but I've read a lot about this issue. They used cholesterol drugs to stop the fat molecules from allowing the virus to transmit. They used different antihistamines. There were all kinds of things that were tried, and some things were very successful, actually. There's a doctor on the other side of the world that used a specific antihistamine, and none of his patients died. So that's what this bill is about, allowing us to try things when there's a pandemic. So anyway, I'll leave it at that.
All right. Did the chairman leave a vote, or does he want to leave it open?
Oh, he can
He
go
left
ahead.
the vote, sir.
He did leave a vote. Okay, Senator Hutchins.
Thank you, Mr. Chair. I'd like to say something that I think we should consider. We're hearing from agencies, we're hearing from the same people over and over again. But last year on the floor, something very, very powerful happened in my eyes. One of our senators was very, very, very sick. And he had a doctor prescribe a couple of these medicines that we've been talking about. And I remember him going to that doctor on the floor and hugging him and thanking him for saving his life. That overshadows all the testimony that I've heard, all the fear that I've heard, with doctors already doing this and us codifying this into law with hopefully an amendment to offer immunity. I don't think to the facilities, but to whatever Senator Barlow said. I just want to keep that in my mind, how powerful that was, seeing the tears from the doctor and one of our senators whose life was saved, and thinking about a hospital saying, we're afraid of this, when the whole reason to go to a hospital is to feel better, is to get better. And for them to say, no, we'd rather just stick with protocol and not help you. It's kind of like what I'm feeling from the group. So on and for this bill, and if you can remember that powerful picture of the two gentlemen hugging because one saved his life with off-label drugs, I'd like to just impress that upon us. Thank you, Mr. Chair.
Further comment? Further comment?
Mr. Chairman. So, Mr. Chairman, I think that there is this obviously a very maybe emotional in some levels. I think it's also an intellectual and one that requires fun, but this is public policy. We're forming public policy here. And so I think there are actually probably 10 amendments I could bring to this bill that I could support it with. And I'm just being candid. But as it stands now, and quite honestly, a couple of those people that testified, one of them a practitioner, is one of my constituents. I don't have the same overall comfort with this bill. So, and I'll be voting accordingly. I do appreciate the conversation. I do think it's important. And actually, I think it probably needs to continue, whether this bill is successful or not. Thank you, Mr. Chairman.
Thank you. Senator Bouchard? Okay. Commend the sponsor for bringing this. Probably, I don't think I've seen a freshman House member work as hard as probably this sponsor has. Ultimately, I answer to those within my district, and I met with my hospital and also received a lengthy letter from my chief of staff opposing it. I asked, is there an opportunity to make something like this work? They said, yes, narrowing it down, more specific. And so ultimately, I spent a lot of time working, even though I'm not in healthcare, I've spent a lot of time making sure that we have good healthcare where I live, to the point of part of a situation where we disbanded from a management program and took it all under our own authorization, running our own hospital under our own hospital district. Most successful I've ever seen in the state of Wyoming. Brought our former chair of Labor and Health over to see it, brought the last 3 governors over to see it, because we have a very, very successful rural healthcare program. So with that, I will support their wishes not to go with this bill. But I do commend the sponsor, and I don't think our discussion is over. And I would be fully on board, even as a sponsor, to say if we could narrow this down and be more specific. So I will be a no with that. So thank you. Go ahead, call the roll.
Thank you, Mr. Chairman. House Bill 119, medical prescriptions off-label purpose. Senator Barlow. No. Senator Bouchard.
Aye.
Senator Dockstader.
No.
Senator Hutchings. Aye. And Chairman Baldwin has voted no. Sir, we have 3 noes and 2 ayes.
2 to 3, members of the committee, House Bill 119 has filled the committee. Thank you to the sponsor. Thank you, Representative Penn.
Thank you, committee.
Next bill up for our consideration, House Bill 65988, suicide prevention. We'll be presenting that bill. We have someone doing 988, House Bill 65. We'll take someone. Go ahead. Yeah, and line up real close so we can tighten this up into a half hour. Go ahead. State name and your
Thank you,
title.
Mr. Chairman. Andy Somerville, Executive Director for the Wyoming Association of Mental Health and Substance Abuse Centers, and we will try to be very quick and get you guys out of here. So House Bill 65 is a bill that in the broad terms establishes the framework for the 988 call centers and quality standards. It allows for the department to have some flexibility in exploring and pursuing the future mobile crisis and additional crisis stabilization services. And then as amended from the other chamber, the bill creates a trust fund account, but does not have an appropriation in it. Mr. Chairman, would you like me to go page by page through the bill?
Just give us the overview, if you would.
Okay. So first couple of pages are definitions that are pretty self-explanatory. Starting on page 3, again, that includes some of the quality pieces in terms of the expectation of the services, both for the crisis centers and the call centers. Starting on page 5, it provides that the department shall designate a crisis center, 1 or more crisis centers by July 1 of 2023, and then list the requirements, including that they are working with the National Suicide Prevention Line or its successor, meets all the requirements for best practices and guidelines. And then that kind of follows through page 7 and the top of page 8. At the bottom of page 8, starting on line 14, you'll see the department may provide essentially mobile crisis teams. Again, that language is supposed to be flexible for the department to allow them to explore that scenario. Starting on page 9, line 9 is payment for crisis services. Again, describing that the department may provide payment for the provision of crisis services of a contact. Again, that is flexible language for the department in the future. Page 10 requires the establishment of an advisory body at the top. And then starting on line 17, that is where the trust fund account information is added. And that goes all the way through the end of the bill. On page 14, there was an amendment, as this was worked through the Revenue Committee in the interim, to provide immunity for telecom providers. That immunity provision that is in the bill is similar to what telecom providers have for 911. And then page 15 is kind of standard language at the bottom in terms of Department of Health needs to establish timeframes to accomplish the provisions of this act. Section 3 on page 15, which is line 16, requires that the Department of Health request an appropriation for the next standard budget for the next biennium going forward. Mr. Chairman, that's the overview of the bill. And with that, I can add a few comments to that if you'll allow.
Go ahead, please.
All right. So, Mr. Chairman, the 988 system in Wyoming has been, well, we've had crisis call centers in the state since August of 2020. We were the last state to come on board with in-state call centers. I'll just say it's incredibly important that we have those in-state call centers. It gives us the ability to directly connect residents that call in either for a suicide concern or in a mental health crisis directly with services on the ground in our counties. Nobody knows our state better than the people that work in our state. And although without these local call centers, they would be forwarded to a random different state that had overflow capacity. If we didn't have local call centers, those folks, while qualified crisis counselors, do not know our state. They do not know our geography and our resources on the ground. And so we do a much better job for our residents by having these local call centers. Since we've started these part-time and kind of worked those up to 24/7 service, starting in July 1 of 2022 last year, I believe as of through December, they had answered 9,700 calls from 307 area code phone numbers from our residents. So I would imagine 9,730 as of December 31st of last year.
Starting when?
August of 2020.
Okay.
So I would imagine as of today, we've probably rolled over our 10,000 call from residents. We know that suicide in Wyoming is a big issue. We are still number one in the state or in the United States in terms of suicide rate per capita. We know that it devastates our families and our communities. I think you'll hear from other stakeholders in terms of the effect it has on our workforce, our veterans. We have a higher than average rate for our veteran suicide in Wyoming. This 988 call center does provide specialized services for our veterans and those populations to help in that. We know that suicide has a devastating effect on our economy. On average, according to the Department of Health, a few years ago, Wyoming loses $1.3 million in average work wages to our economy for every death by suicide. And so that's, as you know, the impacts are far-reaching. This bill, in our view, is really landmark legislation in terms of establishing that the state shall have a local call center, and making that statement that we are going to help take care of our residents and our community members. We know these call centers are effective. We have the efficacy data behind it to prove it. And Mr. Chairman, I would just say that it is one of many tools in the toolbox that as providers.
My question is how, Matt, how does it fit in your overall plan? I mean, there's a whole new push to help with mental health. How does this really make a difference?
Mr. Chairman, the different, how this fits in is this is the front door, essentially, as it's being designed and the education being pushed out by the federal government and our local entities. This line is for anybody that is experiencing a suicide or any type of mental health crisis. It allows another access point. So instead of having to call a mental health center or walking into an ER or having an immediate contact with law enforcement, this provides an anonymous way for folks to call in and get connected into services in a way that works for them. So in terms of supporting our behavioral health reform, it's just adding another intake. With the overall goal with behavioral health reform is to get to people earlier in the process, because we know it improves their outcomes when we can get to them earlier. We see as a critical component to supporting the behavioral health reform efforts of the legislature for the last couple of years.
Thank you.
Mr. Chairman, I I know that there's a lot of information here, but we're short on time, so I'm going to stand for questions at this
Thank you.
point, and then happy to add anything as we go on.
Committee, questions? Questions? Oh, Senator Hutchings.
Thank you, Mr. Chair. Mrs. Somerville, who is going to be manning these phones?
Go ahead.
Mr. Chairman, Senator Hutchings, currently we have two crisis call centers in Wyoming, one in Casper and one in Graybull. Those phones are manned by trained crisis counselors. And they go through extensive training.
Follow up?
Yes, sir. You say there, these types of, the 988 is kind of effective, that we've received 9,700 calls just since 2020. But we're also the highest in suicides. So how effective are they really?
Go ahead.
Mr. Chairman, Senator Hutchings, I would be glad to send the committee the direct studies. They've been looking at this for a number of years because prior to it being designated at night as 988 as a three-digit hotline, three-digit number for the hotline, this was a 1-800 number that was more focused just on suicide. What they show is a high percentage of callers that feel like they've been kept safe, that they were helped, callers that are actually following up with services. And we know those are the key components in terms of trying to keep people safe.
Senator, any more? Go
Yes,
ahead.
sir. During one of the committees that we had, interim committees, there were a couple people that came in, one from out of state, and I can't remember where the other person was from. The lady mentioned that a lot of these calls are just people calling in. We just want to call and talk to somebody. And a lot of them are repeat offenders, as she put it. How valuable do you think that is for our state to just have people use it just to call in to talk instead of really having those lines open for people that really need it?
Response?
Mr. Chairman, Senator Hutchings, that certainly is a portion of the calls. Those are folks that are reaching out because they do need somebody to talk to, and the goal is to continue to talk to them and work with them on referring them into services. I would equate it to some of the same calls that 911 gets. There's a portion of those calls that go into a 911 system that are not necessarily emergencies, and so I think you're always going to have that a piece of those calls. While we certainly want to help the most emergent callers, at this point in time, the capacity of both Lifeline centers allow for those type of calls. In addition, Mr. Chairman, I would add that the call centers also provide follow-up calls. So when somebody does call in with a mental health crisis and are referred to services, those crisis call centers are following back up with them. That is another benefit of having a local call center and something that we wouldn't receive necessarily from an out-of-state call center.
Thank you. With that, seeing no legislators in the room, we're going to go to Ms. Delancey. And with that, also, I'll turn it over to the chairman to take it after that.
Thank you. Ms. Delancey, go ahead.
Good morning, committee. Thank you, Mr. Chairman, members of the committee. My name is Cindy Delancey. I'm the president of the Wyoming Business Alliance, and our organization stands in strong support of House Bill 65. Not only is suicide and mental wellness a public health crisis in Wyoming, it's a business crisis. Having additional resources, as Ms. Somerville has very thoroughly outlined, as a tool in the toolbox for us to help keep our employers in a place where they're in crisis productive, less accident prone, more focused on their work during a period of intense need is a good thing. We've just heard hours of testimony, earlier this morning in this committee about the desire for citizens to help one another and try to be caring for one another. Well, supporting this bill is a way to do that. It's just really a way codifying and helping us establish that framework for a 988 permanent mechanism stood up through legislation passed in the Trump administration to really help us find our way in Wyoming to be able to be preventative and ultimately save costs. the ability to have people that are in temporary crisis reach out to the hotline to identify services and other opportunities to help them address either the immediate need for themselves or their families or friends is a way to avoid potential Title 25 commitment, jail stays, extended hospital stays. I know you heard a lot this morning about children in crisis in residential facilities and the costs and the challenges there. So a little bit of preventative maintenance goes a long way as far as helping people be able to stay in their home in at least in restrictive environment in their community, and additionally cost saver. But in Wyoming and the business community, our people are our most important asset, and anything that we can do to try to help our people be at their best and really move Wyoming out of that #1 position is something that we strongly stand in support of, because unfortunately that is not the #1 that Wyoming wants. So we ask for your support on this bill, Mr. Chairman. Thank you.
Questions for Mr. Delancey? Senator Hutchings.
Thank you, Mr. Chair. I'm having a hard time with a disconnect here. One bill says, let's help our citizens be all they can be, do what's best for them. And then the same group that's against that is like, whoa, let's be for this. How do I reconcile that? Thank you.
Ms. Delancey, if you wish to answer that.
Mr. Chairman, Senator Hutchings, I didn't offer any testimony. I was simply a passive listener this morning.
That's fine.
Thank you.
That's fine. Senator Bouchard, go ahead.
To be fair, your organization actually did a lot of social media during COVID session, supporting the people who opposed bills similar to one we just heard.
If we could, committee, please form questions. We're not here to debate the witnesses. We're here to ask questions and get into testimony. Anything further for these witnesses? Hearing nothing, thank you very much. Agency or departments? Yep.
Mr. Chairman, members of the committee, Stephen Johansson with the Department of Health, joined to my left by Matt Petrie, who's the Senior Administrator of our Behavioral Health Division, who's responsible for overseeing the current 24/7 Suicide Lifeline operations. As was mentioned before, we've had in-state call centers since 2020, but Senate File 66 last session directed our department with ARPA funds to stand up 24/7 coverage within the state. We did that by June of last year and have been operating that 24/7 coverage through 2 contractors ever since. As was explained before, this bill does a couple of things. One, it codifies that direction to my department to continue operating the 24/7 Suicide Lifeline, which right now is basically directed through that session law from last session. And I did want to mention to the committee that with the appropriation that was received from the ARPA funds, we are contracted through, I believe, the summer of 2025. So that is, again, we think we're pretty comfortable with funding through that time period for the Suicide Lifeline operations themselves. So again, the point of this bill, as you heard before, is really to start the codification of that program in the Department of Health now, in addition to seeking some sort of a sustainable funding source for it. As you know, on the House side, there was a debate about a trust fund that's contemplated in the bill. Ultimately, that appropriation was stripped out in favor of direction, I believe in one of the last sections of the bill, for us to bring a standard budget request for the Lifeline operations, which we would do a year from now in the subsequent session for the 25-26 budget. In addition, there's permissive language in the bill allowing my department to pay permissively to pay for certain types of crisis services that as you've heard before, kind of go in conjunction with call centers or crisis call centers that we would certainly do in conjunction with behavioral health redesign that was mentioned before, and to the extent that resources are available and that need is expressed in the communities. With that, Mr. Chairman, again, between myself and Mr. Petrie to my left, happy to answer any questions for the current operations or what is being contemplated in this bill. And
Questions
Mr.
for
Chairman,
the
if I
director?
may,
Go
I
ahead,
should
sir.
mention on behalf of Governor Gordon, you all know that this is behavioral health in general is a huge priority for the governor, one in which we've had numerous conversations, both internally in the executive branch and externally with many partners on redesign and reform efforts that are ongoing. I think I can safely say that the governor's office fully supports this discussion and this bill to more permanently address and establish the suicide lifeline in Wyoming, which my department is running, and certainly continue our support for its operations as well. With that, Mr. Chairman, we'll stand for questions.
Are you sure, Director? Okay. Any questions for the director? Go ahead.
Same question. Last bill, we're against, it's for helping people. This bill, you're for, it's for helping people. That one, we had kind of concrete evidence that certain drugs would help. This one, we have no idea. Help me with this.
If you wish to answer that, Director, go ahead.
Mr. Chairman, Senator Hutchings, just quick clarification. We Department of Health did not have a position on the last bill. We came to point out what I believed was an unintended consequence on the Medicaid side with an administrative complication that would arise. It's my duty to inform the committee of those things so that you can make a policy decision. With respect to your question on evidence, very good question. We don't have definitive evidence on the efficacy of the Wyoming Lifeline to date. What I will say, Senator Hutchings, is we have, especially going back to last June with the performance data that we have and track with our two operating lifelines, the speed to answer, the various metrics that we look at are very good, especially compared to our national call centers, for example. I will say that while it's not statistically significant yet, we have been monitoring this very closely in terms of the Lifeline's effect or potential effect on the suicide rate in Wyoming, both statewide and county by county. We have seen, again, not statistically significant yet, but an early indication of a potential flattening of the suicide rate in Wyoming. So as you know, Senator Hutchings, since about 2001, early 2000s, we've really in Wyoming seen a linear growth in our suicide rate, which to your point has caused me and certainly folks who operate these types of programs to question the efficacy of everything we do on behavioral health, whether it's treatment services, intervention, prevention. I think those are healthy and fair questions. Many of those questions have led to some of our redesign efforts to better focus state dollars on populations that are slipping through the cracks that we actually see ending up in state institutions, correctional systems, et cetera. So long-winded way, Senator Hutchings, of saying, I'm optimistic of what I've seen so far, although it's very early, 6-7 months in of the 24/7 operations, that we could potentially see a flattening of that rate. And we will absolutely report back to this committee and the legislature as we track that progress.
Thank you, Director. Okay. Mr. Petrie, anything to add to that?
Mr. Chairman, thank you. No, I do not have anything to add.
Okay, thank you very much. Okay, folks, committee, we're about to run out of time. We are going to bring this bill to vote even if we're a few minutes late. So what I would ask of you in the room, and if there's any online, if you've already heard it said, say, I agree with what they said, but I don't want to go into no more prolonged testimony. I want to get this moved and done. So if you come up and please fill the chairs, because we need to get this done if we can. But if you got something important that hasn't already been said, please say it. Go ahead, Ms.
Hi, Lindsay Semino, Wyoming Counseling Association. We fully support this bill. We very much like it. I do want to highlight that there is a texting feature that we expect our adolescents and young adults to utilize within this program, and I echo everything that was already said.
We'll do all four of you, then we'll ask a question. Go ahead.
Thank you, Mr. Chairman, members of the committee. Mike Lehman with the Catholic Diocese of Cheyenne. Supporting comprehensive mental health care. To me, trying to think of this model, I think of it as a downstream sort of ability. We know that there's still a stigma for a lot of folks. We know that following our veterans, law enforcement, firefighters, first responders, there is that stigma. So to have an anonymous way for folks to be able to call and get resources, to recognize they're not alone is one part, but it's an important part. So thank you.
Very good.
My name is Ralph Nieder-Westerman. I'm the Executive Director of the Wyoming Lifeline, the call center based out of Graybull. Since 988, the three-digit number went into effect, we've seen an increase in the volume of calls that we've answered. In December, our highest month, we answered 204 calls. We answer calls from 2 a.m. to 4 p.m., and then it shifts over to CWCC. I think that it's imperative that we have in-state people who know the state, know what we face. I agree with everything that everybody else has said. Stigma is there. Sometimes you just need to speak to somebody who will not judge, and that's what we do. Thank you.
Thank you. Go ahead, ma'am.
Hello, Chair Baldwin and committee. I'm Beth Howard, and I'm a mother and a grandmother and a 46-year resident of Cheyenne. I thank you for the opportunity to speak, and I am testifying as a volunteer with Wyoming Moms Demand Action in support of House Bill 65. Wyoming has a couple of factors which put us at particular risk for suicide: isolation and easy access to firearms. Neither of these factors will change anytime soon, and it is of utmost importance for us to save Wyoming lives by the creation and adequate ongoing funding for the 988 Lifeline. From 2011 to 2020, the rate of gun suicide in Wyoming increased 43% compared to 12% nationwide. Guns are the most lethal method of suicide, and access to firearms triples the risk of suicide. In Wyoming, 86% of the gun deaths are suicides. A lifeline is critical. Wyomingites are at risk. There is a cost to not funding this lifeline. Gun deaths and injuries, the vast majority of which are suicide, cost Wyoming $1.9 billion each year, of which $16.6 million is paid by taxpayers. We would be much wiser to invest in life by utilizing a trust fund to provide an adequate ongoing support for the 988 Lifeline. You have a unique opportunity to save Wyoming lives, and I hope that you will by voting to support House Bill 65.
Thank you very much. Any questions for these four presenters? Seeing none, swap out your seats with somebody anxious behind you. Okay, I'm to assume you're the last one that wants to present since nobody else jumped up. Go ahead, sir.
Good morning, Chairman Baldwin. I'm Boyd Brown with the Wyoming School Boards Association. Stand and appreciate this bill is coming forward. We know that we have Safe to Tell out there, our largest number of calls coming into Safe to Tell, our self-harm and suicide. That does not have an automatic person on the other end that is involved in behavioral health. So I think that this is another opportunity to help our young kids turn away from suicide and get help quickly. With that, I'll answer questions.
Questions for Mr. Brown? Senator Hutchings.
Thank you, Mr. Chair. Mr. Brown, students, when they come to you, do you have an idea what the number one cause for them wanting to commit suicide is?
Senator Hutchings, I don't have that data with me today, but I could probably find it through some other information, but I do not have that today.
Thank you, Mr. Chair. And I think it's important when you guys come that you do have information that you kind of know we're going to ask, because when it comes to suicide, and I look at what's going on in our society today, what we're teaching kids, what we're affirming in children, may not be the best thing for our children. And when you start, in my eyes, lying to kids in education and affirmation, then you're putting them in a position, Mr. Chair, if you don't mind, I'll get to the question. You're putting them in a position where they have no hope. What are you teaching in the schools that would provide hope instead of the lies that we're teaching the kids today?
If you wish to answer that question, if you have an answer, go ahead, sir.
Chairman Baldwin, Senator Hutchings, I do believe that we try to instill a lot of things in our students, from having a lot of grit and being able to bounce back and do things. We try to work with them to understand that you don't always succeed the first time. Sometimes you have to work at multiple things. Some students are very gifted in one area and not as gifted in other areas, and I think we try to work from their strengths. So I guess that would be my answer.
Thank you very much, sir. Okay, we'll let you have a seat. If there's no other burning, are there any online burning questions? Nope. Any other burning? Nobody's jumping up and down. Let's close this to public comment. Committee, what's your pleasure? Moved by Senator Dockstader. Okay, committee, any questions, comments? Go ahead, Senator Barlow.
Mr. Chairman, so I think what we're doing here is codifying what is occurring and giving it a path forward. There's two substantive things that I think that are added in this bill that I think are very important. The mobile crisis teams and the crisis service opportunity. Those are things that actually I think take us to the next level in continuum of care. So I'll be supportive. Thank you.
Further comments, committee? Seeing none, let's take a vote.
Thank you, Mr. Chairman. On House Bill 65, Senator Barlow, Senator Bouchard, Senator Dockstader, Senator Hutchings, and Chairman Baldwin. Sir, we have 3 ayes and 2 noes.
Thank you very much. Senate File House Bill 65, 988 suicide prevention is passed the Labor and Health Committee. Senator Dockstader, would you be interested in doing that one on the floor?
Probably.
Okay, up to you. If you don't want to, you can arm wrestle me, you'll win. Okay, thank you everyone for testifying. We will be meeting on Wednesday, but we will be meeting at a different time. We will be starting at 8:30 because that's the governor's prayer breakfast. So, but we will have at least 2 bills in front of us. I just have to decide which ones. Thank you very much.